Yeah,
I'll move.
please do. I changed the chat settings.
Okay. I'll move the rest.
Yashu?
I think we have about a minute left. Divya, all the participants are in now?
Yes, sir. The first 4 are in.
Okay,
And
good.
others will be joining shortly. Pratima Yadav is absent. I messaged you.
Okay, yeah, I got the message.
Yeah.
Yeah. Hi, good morning, Dilip.
Good morning. I thought it is at 9:30, like yesterday.
Okay.
Good morning, sir.
Morning.
Shashank sir,
Good morning,
can we
sir.
start? Yes,
sir. Yes, sir.
It's 10. Let's
Yes, sir.
start.
Let's start, sir. Go ahead, sir.
Okay. Very good morning, good afternoon, and good evening, wherever you are. Today, in fact, mark the final session of the conference presentation under a presentation track on policy implications, chaired jointly by Dr. Shashanka and I. This session essentially brings together 10 distinguished participants representing diverse perspective across research, policy, practice. Collectively, they will share the insight drawn from different country and institutional context, following us to examine the themes from a different angle. Having said that, each participant will offer a focused research output, which is going to be highlighting the findings, experiences, or lessons learned from the policy. Taken together, these presentations are intended to move forward individual cases forward. Rather individual cases towards the shared learning, synthesis, and actionable priorities. As a chair, I'll be ensuring the time discipline. And the first 5 presenters I'm going to chair, and then we are switching to Dr. Shashank. He will be chairing the next 5 participants. And to have a smooth facilitation and transition between speakers, the presenters would adhere to the time given to you. We will conclude the session with a brief moderation discussion, and also we'll have a question and answer session from the participants as well. We encourage the participants to start asking questions. We have a chat system, as well as you can ask it directly. With that introduction, I now invite Priyanka Kumari, who is going to basically talk about divergent mortality trajectories of major NCD among older adults in India, a 2036 forecast. Let's welcome Priyanka. Priyanka, over to you.
Audible?
Yes, Priyanka, you are audible. Now we can't hear you.
Is this my screen is visible?
Yeah, both are visible now, clear, both audio and video. Go ahead.
Okay, thank you so much, sir. A very good morning to all of you. So I am Priyanka, and I am my title of the presentation is Divergent Mortality Trajectories of the Major NCDs among the older adults in India. It's basically a 2036 forecast. So it's basically a study based on the projection of major NCDs in India that has been projected up to the 2036 year. So let's start with the background. So basically, the population of India is rapidly aging, and the NCDs are leading cause of death among the older adults. And the mortality projections are the critical for health system and planning. And based on this, I mean, literature reviews and all these things, I found out that there should be a focus on circulatory respiratory diseases, diabetes, and the cancer. So basically, the study is based on the data source of MCCD data of from the year 2008 to 2020, and then SRS data from 2008 to 2020, and it's based on the population of 60 years and above. So the projection of mortality rates, it's very carried out for major NCDs among the older adults, and the disease projected are circulatory diseases systems, respiratory system, diabetes, and the cancer. And basically for the methodology, a regression logistic model have been used. So here I can say that there are two types of regression models were applied. The first is simple linear regression, and the second one is polynomial regression. And the choice of model depends on the presence first depends on the linear and curvilinear pattern of the mortality trends on in the data or in MCG data and the SRS data. And the second one is statistical goodness of fit indicators, that the indicators of like the mortality or the time. It's basically there is a goodness of fits there. So the choice is based on these two assumptions. So the first linear regression approach is used when the mortality trend shows approximately linear decline or increase, and the model estimated relationship between the time as a predictor and the mortality rate as an outcome. And it's based on the two assumptions, that is there is a linear relationship between the time and the mortality, and the second one is it's normally distributed with the constant variation. And the polynomial regression approach is used uh, uh, applied when the mortality trend shows a non-linear or the curved pattern, and there is a high order polynomial tested sequentially. Then again, the R square and the change in R square is also used to set the model of the order. And there is also prevented overfitting by avoiding the unnecessary higher order terms. So here comes the result. So as we can see in the pictures, that there is that the the mortality of due to NCD declined steadily from 2008 to 2020, and it's still declining. That we have projected that up to 2036 it's declining, but the male mortality consistently higher than the female. That indicates that gain in prevention and chronic care. So here we can see the two pictures. So the first picture depicts the trend of circulatory system diseases, and the second picture depicts the respiratory system diseases. So based on these, projections, so the circulatory diseases mortality shows a strong decline, as well as the respiratory system also shows the same pattern. But the male have a higher probability across the years, which reflect improved treatment, but persistent risk factor. So it's the findings from the projection of the diabetes. It's kind of interesting that here we can see in the picture that the diabetes mortality increased after 2014, and it's also rising up to 2036. And there is also increase in SARPA among the older adults, women, which signals emerging public health cause concern. And also there is also all decline in the cancer mortality, and the reduction is more pronounced among the female, which is likely due to the early detection or the better treatments. And also it's because of the regional and reporting disparities also could be one of the reason. So these are the major key findings from the study, that there is a decline of mortality for the CVD, respiratory diseases, and the cancer. Diabetes shows a rising and the divergent trajectories. Male mortality remains higher, but the trend converges over the time. And the fourth one is the result variation reflect healthcare and socioeconomic differences, and projections represent expected trend in mortality rates, but not an absolute rate. And the last one is that the declining rates may coexist with the rising absolute rates due to the population aging. So based on the results, there are some policy implication there is a recommendation of some policy implication that the first one is to sustain a gain in cardiovascular and cancer care, strengthen diabetes prevention and long-term management. Third one is the prepare health system for aging population. And the last one is to address the regional and environmental health disparities. So here's now I end my presentation. Thank you so much for listening me. Thank you so much.
Yes, Priyanka, you just threw light on the NCD, related mortality, which is more of a technical paper. You did very well. That was a technical presentation. I have a couple of questions to your observation, rather, I would say. See, once, when we look at the NCD mortality decline, that was the first observation from your study. On the contrary, if you look at your own presentation, which shows that the diabetes mortality is increasing. How these two contrary, statements, that's the first one. Secondly, when we think about the global perspective, now it is from the demographic transition to the epidemiological transition, which clearly indicates that the mortality or morbidity and mortality related to the infectious diseases are going down, and subsequently the non-communicable diseases mortality is growing fast. In that context, how do you justify this one? Over to you.
Sir, answer to your first question that there is a decrease in NCD's mortality, but increase in the diabetes. So basically diabetes is based on our lifestyle factors that and NCD compromises one of the diabetes, not but there are respiratory, circulatory, and there is also detection and the early treatment of the NCDs could lead to decline in the major NCDs, but the diabetes also can lead to that lifestyle factors. Here the people are, no physical activities, no anything, but the people have money to detect, they go to the doctor, and that they have they are more aware about their health because of the social media and all these things. Though now they have a knowledge about. So because of that early detection, it could be one of the reason. And sir, can you? The second question, your second question, sir.
Yeah, which is, see, in the epidemiological transition, when you look at that, infectious diseases are going down and NCDs are going up. In that context, how do you justify your research that NCD mortality is going to be down until, from the 2036? That's my question.
So, sir, in the epidemiological transition that based on these things, it's not purely based. There could be, there are some limitation of data also. So, I again repeat that it's basically because of the exposure and the early detection. It could be one of the reason because of the decline in the mortality, not morbidity. It could be a morbidity, but the morbidity due to NCD could be higher, but the mortality due to NCD it's declining up. So it could be one of the reasons, sir. So
okay, yeah, thanks for that. But I just work on that. See, I gave you this thought just to work on it. And my last question is related to your policy implication. What are the policy implications? 5 points you have given as essentially which is already working. What is new? See, as a young researchers, our expectation could potentially be coming up with the new ideas on the policy points. I'm not expecting an answer from you now, but think about that. Now, whenever you make a presentation, it should be specific to what you have done it. These policy implications are in general. Okay. Anyway, with that, I'm requesting Shashanka sir. Do you have any questions?
No, sir. No, sir. No, sir.
Okay. So then, any questions from the audience? quickly, we're going to take a couple of questions. Audience?
No, sir. We can
No.
continue. No, sir.
Okay, thanks, Priyanka, for the wonderful presentation. And now this next
Thank you so much.
presentation, the next presentation is from Abhishek Kumar Singh. He is going to talk about legal and constitutional framework on elderly rights in India. I think it is a relevant topic, the current context. Hope we would enjoy that. All the very best, Abhishek. Over to you. Abhishek, are you there? Divya?
Yeah, he's there, sir.
Okay, he's
In
fixing
the
it. All right,
panelist.
good. Okay, right.
Maybe he's on mute actually, sir.
Okay.
Hello, sir.
Can you hear us?
Yes, sir. Yes, sir. I'm presenting, sir.
Yeah. Take your own time. No worries.
Now it is visible, sir.
It is visible. Can you make it in the presentation mode?
Okay, sir.
Good.
Okay, sir.
Go ahead.
Good morning, everyone. Respected chair, distinguished panel member, and fellow delegates. I am Abhishek Kumar Singh, a research
Lost your audio, it seems. Abhishek, I think you are on mute.
No, sir.
No, we lost your audio. Go ahead.
Actually, sir, there is a little bit internet connectivity problem, sir. That's why.
Okay. Go ahead.
Investigating the role of public policies in enhancing the well-being of the elderly population in Delhi. This presentation examines how existing public policy address the socio-economic, health, and welfare challenges faced by older adults in a rapidly urbanizing metropolitan context. Population aging is a natural outcome of demographic transition, but it is also represent a critical and sensitive phase of human life, affecting individuals physically, mentally, and socially. India is currently experiencing a rapid demographic shift, with the proportion of people aged 60 years and above projected to reach nearly 19% by 2050. This transition introduces complex challenges, particularly related to chronic illness, disability, declining cognitive capacity, and social vulnerabilities. Ensuring dignity, security, and well-being in later life, therefore, require not only policy intent but also effective institutional mechanism and inclusive governance framework. Coming to the background, urban aging in India is intensified due to declining fertility, increasing life expectancy, urbanization, and migration. Traditional family support systems are weakening because of nuclear family structure and labor mobility, increasing elderly dependency on formal welfare systems. While cities offer better healthcare and infrastructure, access remains highly unequal, especially for the elderly individual, with informal employment histories and limited pension coverage. Rising living costs, poor walkability, lack of age-friendly urban design, and reduced social participation further contribute to economic and social vulnerabilities among the urban elderly. Aging in Delhi. Delhi represents a particularly critical case for urban aging. It has the highest average decadal growth rate of elderly population, around 6.6% among major Indian states. The city is characterized by high population density, socio-spatial inequality, and uneven service distribution. It also faces some key challenges like income insecurity, limited access to affordable healthcare, inadequate age-friendly housing, social isolation, over-reliance on informal sector work. Additionally, increasing digitization of welfare scheme services often excluded elderly individuals with low digital literacy. There are some certain policies related to elderly population. India has established a comprehensive national policy framework for elderly welfare, including national policy on older persons, maintenance and welfare of parent and senior citizen act, national social assistance program, national program for healthcare of the elderly. And at the state level, Delhi government has introduced schemes such as old age pension, free or subsidized public transport, healthcare through government hospital and mohalla clinics, daycare centers and shelter home for destitute elderly. However, the effectiveness of these policy depends heavily on implementation quality. Coming to the objective portion, the primary objective of this study is to evaluate the effectiveness of existing public policies in addressing elderly well-being in Delhi. Specifically, the study aims to identify gap between policy design and ground-level implementation. Second, assess institutional support and community participation in elderly care. And third, propose governance and policy reforms to improve service delivery and inclusivity. By integrating local urban realities with national and international best practices, this study contributes to broader discussion on inclusive urban governance and sustainable aging. This is my study area. This study focuses on Delhi with particular emphasis on districts such as Southwest Delhi, North Delhi, West Delhi, Northwest Delhi, and Central Delhi, which have the highest absolute elderly population. This study adopts a qualitative and descriptive research design. It is based on systematic review of national and state level policies, critical analysis of legal and institutional framework, primary survey data collected from the elderly respondent, around more than 100 participants. A thematic analysis approach was used to identify recurring pattern related to policy implementation gap, service delivery limitations, institutional fragmentation, interdepartmental coordination challenges, and the finding were contextualized using national and international best practices in aging governance. Result and finding. The finding reveals that Delhi possesses a broad and comprehensive policy framework, yet implementation remains uneven. There is a clear disconnect between policy intent and on-ground execution, driven by bureaucratic complexity, delayed disbursement, weak monitoring mechanism, lack of outcome-based evaluation. Institutional fragmentation results in duplication and inefficiency, while digital welfare platform, though efficient, create new form of exclusion for digitally illiterate elderly population. There are certain mental health policy for the elderly. Mental health remain an under-addressed dimension of elderly welfare, despite the availability of healthcare schemes such as uh, Ayushman Bharat, Rashtriya Vayosri Yojana, and there are several government schemes like Social Security and Pension Scheme, that is Indira Gandhi National Old Age Pension Scheme, Pradhan Mantri Vaya Vandana Yojana, Atal Pension Yojana, scheme related with healthcare and wellness scheme like National Program for Healthcare for Elderly, Ayushman Bharat, and welfare and shelter scheme like Integrated Program for Senior Citizen, Vayoshreshth Samman. Preventive care counseling and community-based mental health support remain limited. Social security scheme like Indira Gandhi National Old Age Pension Scheme and Atal Pension Yojana provide income support, but coverage and adequacy vary significantly. There are certain recommendations, that is strengthen institutional coordination, improving monitoring and evaluation system, balancing digital and offline service delivery, promoting community-based care and neighborhood support, integrating age-friendly urban planning, targeting vulnerable elderly group, aligning policies with global agency framework. These steps are essential for inclusive and sustainable elderly welfare. Coming to the conclusion part, in conclusion, we can say that while Delhi has a strong policy foundation for elderly welfare, implementation gaps significantly reduces effectiveness. Elderly well-being depend not only on the policy availability, but also on accessibility, inclusivity, and responsiveness. Adopting integrated care model, age-friendly urban planning, and participatory governance can greatly enhance outcome. Inclusive, community-driven, and feedback-based reform are crucial for ensuring dignified and securing aging in rapidly urbanizing cities like Delhi. These are field survey data photos, and thank you.
Yeah, thanks, Abhishek, for this presentation. Again, I have some observations here. Starting with when I looked at your title, I was so very happy that you are going to evaluate the effectiveness of the policies related to the aging. But when you made a presentation, I didn't find any effectiveness evaluation by applying any statistical or any empirical model, which was missing in your case. First of all, when we start doing any kind of effectiveness, you should use a framework on effective. There are 10 number of frameworks available across. So that is going to be the one which was missing here. Secondly, you said it's a qualitative descriptive study. What are the qualitative tools you used for collecting data? Last, I saw a couple of photographs, maybe a focus group discussion or a key informant, whatever it could be. That was not clearly mentioned in this one. How many FGDs you have conducted, how many in this one. See, that is the core of the presentation. When a researcher present in a forum like this, it's going to be attractive, right? Okay. Then what I could finally found that it is a snapshot of the elderly welfare programs in India and in Delhi. And recommendations, as I made a comment in the last one. All of you all are budding, youngsters and are going to be in research. Your recommendations could essentially be touching upon your findings. If you have a findings, based on that finding, draw a policy recommendation or whatever it could be. Never make it randomly saying that these are all are this one. So this is all for all the participants here, right? With that, Shashank sir, do you have any questions?
No, sir. I think you covered it. No, sir. No, sir.
Okay. So anybody from the audience?
No, sir. No, sir.
No.
Not at this.
Okay. Okay. Once again, thanks, Abhishek for the presentation. And then next, I'm moving to Shweta. She's going to talk about can loss replace love? Testing the effectiveness of India's Maintenance Act. Shweta?
Yes, sir. Yes, sir. Good morning, sir.
It is a turn for you. Go ahead.
Yes, sir. Thank you, sir. Good morning, everyone, to all the esteemed panelists, and thank you for attending the presentation. My topic today is Can Laws Replace Love? Testing the Effectiveness of India's Maintenance Act. So I'll just walk you through some brief background on how we started off with this research question. It's still a work in progress. Sorry, can you see the slides moving? Yeah.
Yes, we can.
Okay. So the population growth of seniors in the country has been growing. We have been discussing over the last 2 days, now the third day, that there has been a significant increase, the increase in the proportion of people or the number of people who are seniors in the country has been much higher than compared to the overall population. And we can see that from the decadal population growth as well. Among the 60 plus, when compared to the entire overall population, the growth has been substantially higher. And alongside this, there's also the social fabric of the family that is experiencing changes. Children are migrating outside from their native home, from the native homes to in search of better opportunities, or they are also preferring the smaller family size is getting preferred now. So the cohesion within the family is also declining to some extent because of the influence of West also. There are studies that say that Western influence is there. Urbanization is also one of the reasons. So multiple reasons are leading to the family getting smaller and smaller. And this is leading to an increase in the proportion of elderly who are living alone or with spouse. Like we also discussed in the panel discussion that almost 7% are actually living alone, as per the LASI data also. So the proportion of people who may not have a very direct support from their family is also declining. So this basically taking cognizance of all these social dynamics and the population increase, the demographic structure changes, the government introduced the Maintenance Law Act, which Abhishek also discussed in the prior presentation, which basically meant that any senior citizen or parent who is unable to maintain themselves, they are entitled to apply for a maintenance from their children or grandchildren. Especially the inheritance law is basically directed to those children or grandchildren, that the rights to the property of the parents will be directed to the children or grandchildren. So one major change of this was that both sons and daughters are now liable to provide for their parents, unlike earlier, where it was perceived as per cultural norms that only sons are responsible. And of course, there are punitive actions like fines and imprisonment. But why the government might have introduced this law, because laws are also catalyst for social changes. So once laws are in place, it sets in wheel the machinery, which can actually impact the social cohesion. So what we are trying to do in this working paper is basically we are trying to see whether the Maintenance and Welfare of Parents and Senior Citizen Act, has it been effective in enhancing the welfare of seniors in India? So we do it through an empirical approach. The analytical approach that we use is that we basically leveraged the staggered implementation of the timing of the act. So the act was not implemented at the same time, because this act purview, the purview of the act falls, the act falls under the purview of the concurrent list, where the state as well as the center have a control. So the implementation of the act was not uniform across all the states. We specifically pick up two states, Bihar and Jharkhand, wherein the implementation happened, actually it happened first in Jharkhand and happened later in Bihar. And because these two states have been actually separated very recently, so we can actually see how the effect of the act has been in Bihar, in Jharkhand vis-a-vis Bihar. So taking Jharkhand as the treatment state wherein the act was implemented, and Bihar as the control state, which was awaiting implementation when the act was already passed and implemented in Jharkhand. So we take these two states as treatment and control respectively. And we use difference and difference approach. So what difference and difference approach does is that it basically compares the outcomes in Jharkhand post the implementation of the act with pre the implementation of the act. And it compares this difference with the difference in the post and pre of Bihar. So basically we are trying to remove all the other dynamics that could have impacted the change in the effect of the act in the treatment state of Jharkhand and comparing it with the control state of Bihar. This approach has been used by Muralidharan and Prakash also when they were analyzing the policy impact of giving a bicycle to girls in school. So we also leverage the same thing. Our specification for the DID and for a parametric estimation is basically we are trying to see whether our outcome is a function of the treatment group, which is whether being in Jharkhand, how did that influence the outcome? How did the time period influence the outcome? So both the time period being in Jharkhand and then an interaction term of two, which is TI and PI. And delta is what the DID effect is, what the DID effect is going to be, which is an interaction term of the time and the state. So basically, compared to pre-period, how Jharkhand improved and how did that compare to the Bihar state. We also used a propensity score matching to further ensure that we get a common support, which is basically trying to, since we did not have multiple panels, we only had 2-period panel, which is IHDS in this case. So we could not measure certain assumptions which DID takes into account, like parallel support, which is basically that Bihar and Jharkhand should be much similar prior to the implementation of the act. So because we could not test it, we also used a propensity score matching method, which basically identifies common support or common kind of households in both Bihar and Jharkhand and then compares those. So Bihar and Jharkhand are also very similar across multiple parameters in terms of the percentage of elderly people in the total population. It's quite similar, 7.4, 7.1%. Who report illness is slightly higher in Jharkhand actually, which is 16.5%. So basically this comparison in terms of multiple metrics, what it tells us is that what kind of controls we should be taking in the parametric equation of DID. So we have taken the health status of the, I'll show you. So we have taken IHTS panel 1 and panel 2 data for making this estimation. The outcome variable that we are measuring in this case, which is a measure of the welfare of the older household, it is per capita total medical expenditure. So we have taken the total medical expenses on real basis for both the ways, for both the states, including outpatient and inpatient. And we are normalizing it by dividing it by the square root of the number of elderly people in the household. And the second outcome that we take is the proportion of medical expenses as a function of the total household expenses. So basically, we are taking medical expenditure as a function of how to measure the welfare of the older households. We acknowledge that this is not the perfect measure of the measurement of the welfare of the older members, but we bank on some studies which have also done, which have used a similar approach, and also that it is known that the expenditure on health facilities, on medical expenditure, it actually increases. It is higher in case of people who are in case of only elderly households. So this is also known. So we are kind of using this as a proxy to measure the welfare. While I'm very much open to looking at other, if the panelists have other recommendations on the welfare measures. We are also trying to figure out some better measures. Some of the control variables that we had seen was the income of the household, because we also saw that Bihar and Jharkhand actually differ when it comes to the per capita income. So we took controls of income. We took whether they were living in the urban region or the rural region, because it can impact the accessibility of the healthcare system. The age of the oldest member was also controlled for, because of course age is also increasing with time. So that can also impact the expenditure of on the health related expenses. We also controlled for ADL limitations, whether the elderly were having any limitation with their activities of daily living, any morbidity that they had, the caste, the religion. So multiple controls were taken. Actually, these are some of the main controls. And by taking these controls, we try to see how the per capita total medical expenses has changed and the proportion of medical expenses has changed over time in both the states. So what we find is basically that, so I'm just showing the main effects over here. The first column that you see, that is without controls, and the second column is with controls. So we had a total of 860 observations. And the DID effect basically tells us that we have taken the per capita medical expense in log terms. So the log of per capita medical expenses that has actually increased because of the implementation of the act. So basically, Jharkhand actually, on account of the act, Jharkhand is able to see an increase in the per capita medical expenditure. So because of the act, the expenditure increases by 1.13%. And if we take controls, it increases by almost 1.2%. So what this shows is that act might have been effective in increasing the expenditure after controlling for the income and taking in real terms. So this is a very marginal improvement. In fact, if we take it in the rupee terms, it actually translates into 300, 400 rupees only. But still, it shows a slight improvement. But we also looked at the proportion of medical expenditure next, which is how the proportion of medical expenditure in the total household has actually changed. And we do not find any significant effect when it comes to the proportion of medical expenses, which can also mean that while the expenditure has increased, it might have increased in line with the income, but as a total household, there has not been a differentially higher allocation towards the medical expenditure. So healthcare utilization might have gone up, but whether it has gone up to the extent that the family is contributing more towards this particular line of expenditure is a question mark actually. So basically we see that the expenses have increased, but households have not reallocated towards health expenditure, which can also mean that they have not reallocated their expenses more towards elderly. But of course, the analysis is fraught with limitations. It's a longer term horizon can provide a better view, because the effectiveness of the act is also questionable. The awareness of the act is still quite weak. So a longer term horizon can provide a better understanding of the effectiveness of the act.
1 minute left, Shweta.
Yeah. Yes, sir. And the medical expenses may be low if at-home care is also higher. So we have not even been able to control how the at-home care has been. If that has been there, then probably the expenses would have been could be low. And welfare measures need to be analyzed beyond medical expenses, like we already said. Some of the policy implications, the act is, of course, the awareness is quite limited. As per last year, also only 12% of the older adults were actually aware of this act. The first case itself was filed in 2011. And then legal hurdles can also be a potential deterrent for justice seekers. So basically, even for the parents who are looking to seek justice, for them also, the legal hurdles present in the country can be a deterrent. Social stigma is another reason why few people would be taking this route, even thinking of taking this route. But the one important implication is that the policy also needs to recognize the caregiving role. And only giving legal mandates might not suffice, and it should be complemented with incentives for the caregiver through tax incentives, through government schemes, and of course, a robust social protection mechanism. So that is it from my side. Thank you, sir. Thank you, ma'am.
Okay, thank you, Shweta, for this presentation. It looks very, highly technical presentations, but I have a couple of questions. One,
Yes,
once
sir.
you have taken as a control as Jharkhand, the first and foremost, you already mentioned that about the per capita, which determines several factors when you talk about the healthcare spending, which
Yes, sir.
you overlooked or purposely you have taken it for
So
the.
I actually controlled for the household income, sir, in my specification. So basically, by
Okay.
controlling for household income, I'm able to account for the income contribution to the expenditure.
Okay. So, and secondly, medical expenditure does not alone tell you about the effectiveness of the policies and programs.
Yes, sir.
But what you could have done, you could have taken some of the other factors like, see, now we talk about social capital, which is hardly people are explored in that. What is social capital? If you would be able to further get that data and adding to this, it's going to give a different flavor for your paper. It is good with that. And similarly, a couple of qualitative information could further improve your findings, right?
Okay, sir.
But one of the interesting factor which I don't know, after the implementation of the program, which was reduced by 1.2 percentage.
Increased.
It increased to 1.2 percentage. Okay.
Yes, sir.
Which is not a significant change when you compare with that, right?
Yes.
But
I
I
mean,
think
practically
over
not,
the
yes.
over the years, maybe that reflection could come to the data,
Yes, sir.
right?
Yes, sir.
Yeah, that's it, and it's a very good attempt, and you also already mentioned that it's a work under progress, right?
Yes, sir. Yes, sir. Thank you so much, sir, for your comments. Yeah.
All the best, Shashank sir.
Yes, I have one observation and a question, future question, I guess.
Yes, sir.
So the laws, carrot and stick approach, right?
Yes, sir.
You touched one of the carrot in your last point. The stick approach is law, but at the same time, the socio-economics and cultural aspects makes a challenge for everyone to pursue the course of the law. Family to stigma and all those things, right? But incentivization of social care, elderly care is a carrot approach, right? Do you
Yes,
see
sir.
yourself pursuing a little bit more into that conversation in the future? I'm pretty sure you can find parallels across different programs, whether it is at state or central, where you can see a carrot and stick approach, but you can bring those parallels into your research in this context where, whether it is tax incentivization or some other incentivization from the government as a policy. So just curious whether you're interested in pursuing that direction in the future or not.
I am, sir. So this is my area of research. So I'm actively actually pursuing how to see basically how the welfare is actually getting improved. So this is also one line of research that I'm looking at, which is comparing law enforcement with other measures, whether other social measures, the carrot measures actually work out better. But I'm still figuring out what could be a proper mechanism to make that analysis, because I'm an empirical researcher.
Okay. All right.
Thank
Good
you so
luck
much,
to you.
sir.
Good luck to you.
Thank you so much. Yeah, thank you, sir.
Any questions from the audience?
No, sir.
No.
Good to
Okay.
see you.
Thanks, Shweta. All the best.
Thank you, sir.
So now moving to the next presenter. One presenter is absent. Now I'm going to the next one. Pankaj. Pankaj is going to talk about intersection of National Social Assistance Program and the digital governance, a situation analysis of pension schemes of older persons, old age in rural India. Pankaj, are you ready?
Yes, sir. Yes, sir. So
Yes,
yeah,
go ahead.
just
All
let
the
me
best.
the 1 minute. Just I'll be sharing my slides. Yeah.
No worries.
I hope my slides are visible now.
Not yet. It is, buffering problem. Yeah, we can.
Yeah. Yeah. So good morning, everyone, and thank you for giving the opportunity to share my little bit mind. So basically, just I'm going to discuss on the intersections of the National Social Assistance Program and the digital governance, the situation analysis of the pension scheme for the old age in the rural India. So this is a conceptual framework which I have often some information from the existing literature, as well as somehow I have incorporated some of my observations on the field where I have visited some 2-3 places where I'm working on the one project on the quality of life of the senior citizen in the respective rural area. So this presentation is based on the most probably secondary data, but somehow some observations I have incorporated out by the interventions. So basically the presentation has been divided into the major 4 parts. It's the first is a background. The second is a methodology, and the third is a pension schemes and a direct benefit transparent issues at a rural area, and what are the ground realities and what could be the way forward to strengthen these pension schemes to the respective beneficiaries, those who are resides in the remote areas specifically. So when he talks about the background of the paper, so this paper reframes the pension schemes for the aging as a social and economical protection situations or the phenomena in the rural part of the country, most probably remote areas where the most of the people are facing the problem to access the actually basic amenities and the basic services, as well as that paper is arguing about the what kinds of the care and what are the benefits and what are the major hurdles in terms of the digital transformations and digitalizations, and how it's leading the vulnerability among the senior citizens, specifically those who are the above 60 and the 70 age of the years. And the third paper argument is about to social assistance. It has to be understood rather than the isolations, basically, because social assistance program has made for the upliftment of the rural people and the vulnerable people. It has not to be isolated at any cost. They have to have a make sure that every person has to get the basic rights, specifically the senior citizens. So that's why the government of India has came forward with this National Social Assistance Program, under which there are the 4 major schemes have been launched by the government, in which Indira Gandhi National Pension Schemes is one of the most important programs which launched by the government in 1995. But somehow social security for the senior citizens from the below poverty line still are like it's not reached up to the unreached because of certain reasons or because of certain the hurdles at a grassroots level. So this is a United Nations, the development economic just wait. In 2025, as you know, that we are just going to finish our 2025, and the elder population 16 above will grow up to the 11.1%. And today context, the changing pattern of the social system, such as the shifting from the joint family to nuclear family, and from the migration because of the livelihood, the vulnerable populations resides in the backside in the rural area. So that is the main concern. So that's why the well-being and the comprehensive welfare of the elderly at rural areas is most important priority, and it's a issues of the concern. So that is the most important thing that in the coming decades, by 2020 to 15, the elderly population in India will reach around the 330 million as per the last year's survey. So the main concerns of this particular National Social Assistance Program, and specifically Indira Gandhi Pension Scheme, the ground reality is very different, because since we have the very good program on the paper, but on the ground, the most of the elderly populations are not that much of the informed by the respective local authority. Might be they are not aware about these particular benefits. The majority of the elderly populations have not heard about this Indira Gandhi pension, as well as the pension for the widow. There is another program that is a national pension scheme for the widow. That also is very important to make sure that this information has to reach up to them. In spite of many efforts in social security pension scheme, senior citizens, a large elderly population section still vulnerable. So despite policy advance and expanded coverage of the old age pensions over the past 2 decades, rural older population continue to face multi-dimensional insecurity. which include limited coverage, low benefits, administrative exclusion, gender disparities, and the barriers to access. This is very important. The last but not least is a very crucial part that we need to address the issue at remote area where the network is the issue. Aadhaar linked payment system is one of the new program has launched by the government. So that's why the direct benefit transfer is producing the new source of the exclusion, specifically those senior citizens, those who are not having that much of the scope to mobility from one place to another place because of the age concern, because of the health concern. So the methodology of the paper is based on the secondary source, and the present paper, the main aim to study the current landscape of the National Social Assistance Program with focus on the pension scheme, and to assess the implementation outcomes in rural areas and interrogate how digital governance leads to exclusion for the older and vulnerable population in the rural areas. The statistical and conceptual data used in this purely from the secondary source, but somehow we have observations from the field that I have incorporated in that to understand the ground reality of the direct benefits, to analyze the current situation of the KYC, know your customer system in the remote rural areas, and to suggest a mechanism to hurdle-free access the pension benefits. And these are three questions that I have raised. What is the ground reality of the digital governance in the connection with the pension scheme? Second question, what are the issues pertaining for KYC relation to old age pension scheme? And third, but not least, how can enhance the access of the policies to elderly in terms of the barriers-free access of the pension benefits? These are the three questions that we have. We try to answer this question, try to understand the answer of this question by visiting the certain area of the rural part. And we came across that there are certain issues pertaining of this particular issue.
You have 3 minutes left. Still
yes,
you are
sir,
in
yes.
methodology.
Yeah. So this is the overall pictures of the elderly population in a million. You see these are the certain population that right from the 1961 to 2020, 2011, 2021, 2031 still is it's not done. But somehow the population of the elderly is increasing. If you see the rural part of the country, the population as per the 2011. 73.3% populations are resides in rural area compared to the urban context, because the urban area only the 30.6% population, and compared to the male and the female population is 51.1% and male population 52.8%. But rural part of the country is having the huge range of the population of the rural, and this is a overall the male and the female population, because if you see the 5.27 female populations are above 6 and above. So overall 8.97 population is from the female compared to the men. So female are the most vulnerable populations in the rural part of the country. So this is social protection during the lifestyle. If you see the infant, children, working age, adult, and elderly, these are the 4 stages that we goes from our birth. So elderly having certain kinds of the adequate income and healthcare, then they can have certain kinds of the good health and good dignity and prosperity and quality of life. Like the children must have to have a healthcare, nutrition, school, and enrollment. Similarly, working age adult also requires certain kinds of the allowance, unemployment benefits, and the work accident insurance. Similarly, elderly need to have certain kinds of the income and healthcare services on time in their doorstep. So these are the ministry. I'm not going too deep because these already have discussed the previous presenters. These are the 3 ministries: Ministry of the Social Justice Empowerment. They have integrated different type of the schemes and the programs. The Ministry of the Rural Development specifically are focusing on the National Social Assistance Program, Indira Gandhi National Old Age Pension Scheme, and Indira Gandhi National Disability Pension Scheme. So those are the 1669 above, they can get the certain kinds of the pension, but pension scheme and the pension amount.
Sorry, Dr. Pankaj, you can do it because your time is 15 minutes. Only you have 5 more minutes. You can go ahead now.
Yes. So this is the status of the old age pension scheme across the country. If you see this structure of the old age pension scheme, Andaman Nicobar Iceland is giving the much pension because 2000 is depend on the population, depend on the budget of that particular state. It's also, and the Kerala also leading state where they're giving the 2000 pension. The Pondicherry giving the 2000 pension, but somehow there is a certain areas where you can see the 500 to 200, 300 is the 200 pension is very low. In the Manipur state is given 200 pension. So these are the certain the remote village and the issues of the KYC. The specific issues related to the non-completion of the KYC procedure in the remote villages, where the eligible elderly people are been waiting since last 1 year to get the pension amount under the Indira Gandhi National Old Age Pension Scheme and Shravan Bal Pension Scheme. This is a state government scheme. And the ground reality is that the pension schemes now linked with the Aadhaar authentications and direct benefit transfer mechanism require regular KYC updates for the beneficiaries at the bank accounts. And because of the weak network, they are not able to make sure that their KYC can be done at a ground level. And lack of transportation facilities and limited support system have severely affect the accessing the pensions amount of the elderly. And poor mobile network coverage is a main concern. And the intermittent internet connectivity and the malfunctioning biometric system have prevented many elder citizens from the completing their KYC verification. And it was revealed that the majority affected beneficiaries are above 70 years of the age with limited mobility, absence of the family support since many of the elderly lives alone. Many of them are waiting for their pension since last 1 year, which has been delayed due to the Aadhaar-linked KYC issue, and broader implication for the digital exclusion in welfare delivery system, especially for the vulnerable elderly population in the remote village. So where we have done the intervention, the small hamlet lies about 20 kilometers from the sub-district headquarters and 70 kilometers from the district headquarters. According to census 2011, village population is around 1,200 and have a group panchayat where they have certain kinds of these particular issues. The gap in the social protection schemes and the programs, the lack of implementation, the program have not been reached up to the actual beneficiaries, and constraints of the KYC, Aadhaar-linked KYC direct benefit system, which is the main challenge to those who are 70 above, and even those who are the above 60 years. And accountability in the social protections program, lack of accountability and willpower among the local leaders, authorities, and villagers. Information communication gap is there, infrastructure issues are there, hard documentation procedure, digitalizations too, and the limited social protection coverage. Only few of total population of elderly has been covered by the social protection scheme and the Indira Gandhi National Disabled Pension Scheme and Shravan Bal Pension Scheme. So key issues and challenges: lack of the willpower among the local stakeholders, absence of the proper information knowledge among the stakeholders, limited access of transportation, mobility and networking, elderly isolation and negligence from the family and society, family shift joint to nuclear, which leads to the loss of family support, livelihood and migration of sons, daughters, which leads to vulnerability among the elderly, inadequate social support system to vulnerable elderly population. And these are the key way forward that I suggest. Offline KYC procedure need to execute to ensure that no one left behind, and KYC campaign need to organize by the local authority in village itself to ensure timely issue the pension amount. Simplify pension disbursement process to reduce Aadhaar link delays, as well as simplify the documentation process to avoid the delay in the pension benefits. Third, community-based information resource and service center need to be established to address and solve the issues in the village itself in terms of the social security pension of the elderly population. And fourth, make the local authority accountable, transferable, and responsible to lead the effective service delivery on the doorstep of the elderly population. Fifth, encourage the local youth and strengthen their capacities in terms of the social protection of the elderly at community level. And the last, strengthen the local government system and village council to monitor and execute the all social protection related program and the schemes in accountable manner. Thank you very much, sir.
Sorry, thank you, Dr. Pankaj, for the presentation. It is again giving us a lot of information about various programs across the country. One, essentially you are focusing on Aadhaar linked payment and digital governance exclusion. That was you are one of the major area which you touched upon.
Yeah.
But one question, you said your study is implemented in a village and then you gathered information. Am I correct?
Yes, sir. Yes, sir.
Okay, good. So then one thing was missing, is inside. How did you gather the information from the people in that village? If you add that, it is going to be giving some more sense to the presentation. Then
sir.
another thing, observation is, gaps in social protection, which was, your observation was in general. If you look at some of the states, you already mentioned in one of the table that there are several states performing well. This could have been, vis-a-vis the comparison that would have give more into your paper. Then the key issues and challenges, which are in fact general in nature, could be more specific this one. And one of the important things which you have highlighted in the way forward session is a resource service center at various places. I don't know, did you get an opportunity to look at the model which the government of Kerala I now proposed was, and it's a long term, it's almost 15 years, called Akshaya centers, where they are helping the people, everyone to update your KYC and all those things with a nominal amount. So those things, if you could have done more research into that, these are the things which is already functioning in our country, right?
Yes,
With
yes.
that, I'm okay, Shashank sir is not there. He went out for a quick break. Anyone in the audience has a question? Anyone in the audience? No. Okay. Thank you and all the best, Dr. Pankaj.
Yeah, thank you, sir, for your kind suggestions. So I incorporate all the suggestions and go ahead with all the comprehensive kinds of the study on the ground. Yes, sir. Thank you very much, sir.
Okay, good.
Yeah.
So now moving to the fifth presentation, probably 1, 2, 3, 4, 5. Yeah, fifth presentation, which is Amrita. She is going to talk about life of old age homes, a social and demographic analysis in Goa, India. Amrita, are you ready?
Yes, sir.
Yes, go ahead. All the best.
Hello. Am I audible?
Yes, you are audible.
Okay. Can you share? Can you see my screen?
Yes,
Is it
I can
visible?
see. Can you? It is visible. Can you go with the presentation mode?
Yes, sir. Okay.
Yes.
So good
go
morning,
ahead.
respected delegates and research scholar. My name is Amrita Samoy. I'm a former PG student in Government College Khandala, and my corresponding author is Dr. Neetu Naik, Assistant Professor in Geography in Government College Khandala. And our research paper title is Life in Old Age Homes, a Social and Demographic Analysis in Goa, India. So introduction, as we know that aging population is a significant increase in the number of individual, which is above the age of 65 years in comparison to the younger population and proportion to the total population of a country. So we have here statistics that by 2030, 1 in the 6 people globally will be age 60 or the older, according to WHO data 2023. And India's current elderly population is 153 million is projected to reach 347 million by 2050. That means not only the developed countries, developing countries are also in the verge of aging issue. So, talking about the state, Goa specifically faces an aging population challenge due to a decline in the youth number from over 3 lakh in 2011 to 1 lakh 81,000 as per ASH, attributed to mostly due to the shifting values, nuclear family structure, and immigration. As Goa is one of the developed states, and it has a highest literacy after Kerala and other states. So it is facing an aging population issue. Now, shift has led to the growing demand of elderly care, particularly in old age home. As Goa being the smallest state of India, it has more than 30 old age homes run by the government and charitable trust. Demographic characteristics such as age distribution, gender ratio, literacy level, and marital status play a vital role in determining the living condition of the elderly population. Now, objective of a research paper is to examine the social and demographic characteristics of elderly individuals residing in old age home and to identify or has a limited impact on preventing institutional care. So these are my methodologies. The study area, I have taken 2 old age home, that is Sneha Mandir Old Age Home and Sanjeevan Old Age Home located in Ponda Taluka of North Goa district. So we have altogether sample size is 138. This is the study area map. Here you all can see the Goa and Ponda Taluka. Here I have prepared the Bandoda village map, and within that Nageshi area, and you all can see the black indicates the Sanjeevan Old Age Home and pink dot indicates the Sneha Mandir Old Age Home. Both is located in the close by nearby area. Data sources, primary data we have gathered, we have asked the questions, survey questions to the residents, interview. We have taken of both the key informants of both the old age home, observation methods. Secondary data we have gathered, that is government reports, research articles, census data, WHO data. For the data analysis, we have used both the quantitative and qualitative method. Quantitative method, we have used statistical method, that is univariates and bivariates. And qualitative, we have used inductive approach, deductive approach, and narrative analysis for better understanding and for description. So here my results. So here I have done the cross tab between the two variables, that is age group and level of education of the residents. So you all can see here most of the residents age 70 to 79 and 80 to 89, they have mostly attained primary and secondary education, which reflect the limited access in the earlier decades, whereas 60 to 69, they have taken education such as graduation, they have taken, and mostly they are teachers and lawyers, so well educated people. So that means it shows that in the earlier decade they have a limited access to education, whereas now there was a prevalence to the education, so they have taken education. Then gender and marital status. So you all can see my largest respondents are widow females, which forms the largest group, mainly due to the longer life expectancy and social norms, whereas never married individuals, especially women, also forms a notable share, and few shares is also male. Now, here duration of stay and level of social interaction. So most of the residents staying here 1 to 3 years shows a moderate social interaction, because just now they have enrolled into the old age home, and they show like good social interaction, whereas the residents who have been living there for 4 to 6 years or more than 6 years, they prefer solitary lifestyle, or they don't want to interact with the other fellow residents. So this is mostly likely due to the health or mental well-being factors and all. So yes, so more than 6 years mostly shows less social interaction. So here, number of children and reasons for living in the old age home. So you all can see here major you all can see reasons for living in the old age home is lack of caregivers. So instead they have children, 1 or 2 children, 3 or 4 children, still the reasons for living in the old age home is a lack of caregivers, followed by the health issues and loneliness. So despite it shows that it doesn't if you have a children, it doesn't guarantee you that they will take care of you actually. So yes, so loneliness is the second major reasons, where health issues account a small share. Then then next is number of children and support system. So y'all can see here that elderly residents without children receives the least support. So mostly there are few residents over here who don't have any children, so they have a least support from their family, friends, whereas the children whereas the respondents who have 1 or 2 children, 3, 4 children, they have they get occasional visits from their family, friends, or they rarely receives visits. So which shows that children does not guarantee a strong social support. Then number of children and prior living arrangements. So here you all can see the residents with no children forms the largest groups who previously lived alone, suggesting a link between the childlessness and solitary living. While many elderly residents earlier lived with children or family members, and we have just now we have seen the reasons. So maybe due to the as we have seen the reasons that there was no lack of like healthcare facilities or health issues, or there was no one to look after them. That's why they have ended up in the old age home. Now we have seen several factors like the social interactions, then support system. So we have done a depression test with the residents. So y'all can see here that most of the residents suffers the moderate to severe depression due to the loneliness and lack of family support, and few has a better coping mechanisms through social interaction and healthy activity. So y'all can see, even though we have 138 residents, mostly 41, 28, and they are facing a moderate to severe depression, while very few, that is 26 or 23, they have minimal to mild depression and they are in the verge of depression. So in conclusion, the study shows that absence of caregivers and loneliness are the main reasons for elderly residents to move in the old age home regardless of having children. Then childlessness, widowhood, and weak family support also increases the risk of isolation among the elderly, and strong family bonds and institutional cares and social responsibilities are essential to share the dignity, support, and well-being of the aging population. Despite this to old age home, they have a counselor, psychologist who visits them. Still, they are facing this issues like depressions. Even we have done stress and anxiety test also. So we have also found that they are also in the having experiencing anxiety and stress also. So yes, these are my references, and thank you.
Yeah, thank you, Amrita, for a good presentation. And let me, congratulate in the beginning by, since you have conducted a primary data collection from a couple of old age homes, which is, as a researcher, in the beginning, everyone should go to gather data from the primary source of information, for that.
Yes.
Then, yeah. So,
Yes, sir.
then I have some of the couple of observations as well. One, you said
Yes,
the
sir.
presence of children. Your second objective is talking about the presence of children. See, I couldn't
Yes, sir.
understand that when I looked at your related part of the presentation. See, in the old age homes, they never allow the children. I don't know how you have justified that. Any thoughts on that? Presence of
Yes, sir.
children.
As in,
Yeah. Go ahead.
like they have particular timings, sir, and they allow like Sunday to visit the children in the old age home. So basically, I have asked the questions and I have gathered data like how every Sunday they are visiting them, like, and after the 5 also 5 p.m. every day they can visit. So I have gathered data like mostly
Good.
vocationally they are coming or not. Okay.
Okay.
Yes.
So then one of the important observation on your charts are every thing you have shown it in numbers, which is an absolutely a wrong way of communicating the data. You have almost 100 plus samples. It could have been in a percentage. Never show this thing the numbers unless which is a qualitative piece of information with small numbers. Then you can use the numbers. Otherwise, make it all percentage distribution. Okay? Or is there any particular reason for
Okay, sir.
showing it as numbers?
Yes, sir. I thought because if I am presenting it in the percentage, people won't understand like how many numbers. So that's why, and it is my qualitative data, and I felt that like number is very quite less. So that's why I have presented in the numbers. But
No,
as
yeah.
I understood your
100
suggestion,
is
sir, so I will
100 is
convert it
not
into
a
percent.
yeah, because although it's a qualitative data, you gather all the information like a quantitative one. You have everything.
Okay,
You
sir.
showed everything. I mean, okay, so that could be. Then another one, as you have conducted a depression test using what type of tool you used to conduct the depression test?
So I have asked them the 9 questions, which is recommended by the one psychologist. So there were 9 questions, and the ratings were given like mild depression, severe depressions, and based on that questions, like for example, how many days they are feeling low.
No,
They are
I
not
understood
feeling
that.
like
And
very down, like this question.
my point is, any the scale, depression scale or psychological or
Yes,
or
sir.
psychotic scale
Yes, sir.
should be standardized for Indian context. Is that done, or you just applied it?
No, sir. One of the psychologists, he just gave me that a depression test. That is a PHQ questionnaire.
PHQ,
That is a primary
okay.
health questionnaire on depression. Okay.
Okay. That is standardized for India. It's okay. That's what I want to know from you. And
Yeah.
the findings, are certain different, and your recommendations are not in fact matching. This is throughout everyone. I found this one, right? So keep an eye on it whenever you make the presentation. It should be connected with your findings. Okay. Otherwise, good presentation.
Yes, sir.
Dr. Shashank, any questions from your end?
No, sir. No, sir.
Audience?
No, sir. I didn't see any questions from there as well.
Okay, thank you, all the 4 presenters, 5 presenters. And now we are going to transitioning to Dr. Shashank, sir. He is going to chair for the next 5 presentations. Over to you, sir.
Thank you, sir. Thank you, Anil, sir. Thank you so much. Our next presentation is by Ashraf Abdul Salam on population aging succeeded by demographic dividend, the state of the Arab world. Sir, Ashraf, sir, are you here? Can you hear us? Ashraf Salam? Divya, is he here? I saw him. Divya?
Sir, he has moved out.
Move him to panel. I think he's in the attendees.
Yeah, I moved him. Meanwhile,
We want to go with Bishwajit Bera then. Okay.
yeah, meanwhile,
Okay.
once by the
All
time
right,
he gets,
let's-
yeah, he's moved. So if he's ready, sir. Biswajit can start. And
All right. Bishwajit, his presentation is about association of spirituality and religiosity with mental well-being of elderly in India, evidence from LASI study. Bishwajit, it's over to you. Please go ahead.
So, is my screen visible? Presentation.
Yes.
So, good morning, everyone. I'd like to thank Longevity Asia to present me the opportunity to present my research. So, this is a still work in progress and still an early draft. So, moving forward. So, throughout the entire conversation of this conference, we know that the aging, the share of aged people 60 plus or older adults 45 plus is increasing, and in India it is expected to triple by 2050. So this was my main motivation to start this project. So how mental health is being affected by religiosity or spirituality, because these are the two things which are often interconnected, but not much focus has been given on them. So literature suggests that religion is a critical and crucial in Indian or Asian culture, especially in the lives of elderly. And it has shown to improve the life satisfaction and depression amongst elderly. Most of the research in India are based on specific old age homes, and not and have not utilized nationally representative sample survey. So this was my initial motivation to move forward. So in this research, we have examined the uh, effects of religiosity and spirituality on probable major symptoms, which is measured using CIDI-SF scale. So, so data and methodologies. This uh, study uses longitudinal aging study in India's data set, which wave one data set, and the target population in this is older adults aged 45 and above, and elderly, which are 60 and above. And the analytical sample for this study was 63,734. Major outcome variable is uh, a major depressive symptoms. So in that it is uh, taken retrospectively from the date of interview in the last 12 months, based on how you are feeling, and it is a 7-point scale, or which if the scale is 0 to 2, it is the respondents are not having depressive symptoms, and from 3 to 8 they are having depressive symptoms. So another key predictor variable that I constructed was a religiosity index and spirituality index. So in religiosity, it is basically a behavioral composition uh, uh, carved out of visiting frequency of prayer, visiting uh, religious events, visiting temples, and how important is a religion in an individual's life. So uh, this was the outcome was 0 to 4, uh, which was further recorded into 4 to 9 and 10 to 12. So in this, if one is having higher score, so they have the chance, they are attending less in the various religious events. And next is spiritual index. This was also created. So this is more or less an behavioral, this intrinsic approach. So in this, rather than physically attending something or going out, it is based on are you having feeling of depressions, or are you spiritually touched by the beauty of creation and feeling thankful. So in this, the value ranges from 4 to 20. In this, lower values suggest higher, a more positive side, and higher values are for the negative. So in this, it was created 4 to 16 was spiritual individuals, and 17 to 20 was non-spiritual. Next, we did a basic profiling of the individual, both for spiritual and religious, and then for depression in India. And then we did a regression. So coming on to the results is, we can see that the female respondents have are more religious as per the approach we have taken. And next, with increase in education, we see that the religiosity index is also increasing when we compare to no education. If we go for 10 plus years of education, and when we look at geographically how the religiosity is varying, so we can see that in the northeast region of India and the western region, the people are more religious as compared to the uh, other regions. And among the various religious groups, so Muslim and Christian community respondents were more religious as compared to Hindu or the other religious group. And also in rural and urban areas, which got my attention, that in urban areas, people were more religious. So this was the basic profiling of religiosity among older and adults and elderly in India. So then we move forward using a regression analysis, logistic regression analysis, to see what uh, which variables are having is highly associated with regression with religiosity. So we can see that female participants more uh, were more religious, were more likely to be religious as when compared to the male. and urban residents were also more likely to be religious. So in scheduled caste and scheduled tribe, respondents were less likely to be religious, and these are for all the significant, were statistically significant. Next, we go for spirituality. So in this, we see that males were more spiritual, even though the difference is not much, but slightly higher spiritual than females. And with increasing education, the respondents were more spiritual. And in the when we look at geographical regions in India, so the western region had comparatively higher spirituality index scores when compared to the rest of the respondents. And in the religious group, when we look at the Christian and other religious groups, they were having a higher spiritual score. And also in the urban areas, the respondents were more spiritual. And then we go for the determinants where how which are more likely to be religious. So in this, when we control for other variables, we can see that females are more likely to be spiritual, which was different from the result from cross tabulation. And with increasing age, uh, with in with increasing years of education, we can see that the people are more likely to be religious. So these were some of the findings. Next, we move at the central theme that how religiosity and spirituality influences mental health. So in this, we can see that uh, the religious group and the spiritual group less uh, had less depression when we look at the non-religious or non-spiritual group. Accordingly, if we move for the profiling of depression, we can see that the central region of India, specifically Madhya Pradesh, Chhattisgarh, those regions had higher depression. And when we look at the marital status of the respondents, so the currently married and never married had less prevalence of depression as compared to the divorce or widowed group. And when we look at the living arrangement, so when the respondents are living alone, they are having higher depression. So next is this is the main table that I wanted to highlight. Before it was two different groups of spiritual or religious. In this analysis, I have clubbed them into a single variable in which in which it is four categories. They are neither religious or spiritual. They are religious only, they are spiritual only, or they are both religious and spiritual. So we can see that if they are religious only, so it is not significant with depression. But if they are spiritual only or both religious or spiritual, they are less likely to be depressed. And another major factor that came out on the study is the morbidity. So if an individual is having some morbidity, they are more likely to be depressed. So these are some of the findings that came out of this undertaking. So we can see that spirituality helps in mitigating major depressive symptoms among older adults in India. And uh, uh, also as the religiosity and spirituality were treated differently, were computed out of differently. So religiosity is more of a behavioral or external factor because it was derived out of action. So if they are going for a prayer or they are involving, whereas spirituality was more or less intrinsic based out of intrinsic values. So in which we can see that even though a person is religious because of he's attending or not attending any event, but the inner conscience of or the inner mind of the individual is much more affecting the helps in reducing depression. So that was from my side.
Thank you, Vishwajit. A quick comment, Vishwajit. Your results that you're showing using bar graphs, the
Yes.
y-axis is not calibrated. You need to look into those representations again. Your y-axis is not calibrated. Okay, just be careful next time. Okay, all right. Our next presentation, we can go back to Mr. Ashraf Abdul Salam. Looks like he's here. His conversation is going his conversation is going to be on population aging succeeded by demographic dividend, the state of Arab world. Sir, over to you.
Can you hear me?
Yes, we can hear you and we can see your presentation as well.
Good morning. Population aging succeeded by demographic dividend, the state of the Arab world. The Arab world is a distinctive region in terms of geography and population. It spreads over 2 continents, shares a common language and lifestyle. With a rapidly declining death rate and a slowly declining birth rate, the population has grown remarkably since 1950. The resultant youth bulge, a rapidly growing youth population, pressurizes society, economy, politics, labor market, education, housing, health, and public utility services, which in turn influence family formation and future population growth. The higher proportion of youth in this population declines with the increase in the number of aging persons, showing a significant gain in life expectancy. This region has great potential with the positive economic effects of a fast birth rate drop leading to the prevailing age structure as a flywheel of economic growth. Moreover, the demography of the Arab countries is changing faster with increasing life expectancy resulting in population aging and the aging of the aged demanding social policies for care with strengthened relationships between the state, family and wider community. The Arab world shows an optimism of demographic stabilization conducive to progress and gains. The profound demographic transition affects marriage, families, childbearing, child rearing, the status of women and the care of the older persons. The Arab world is passing through a demographic transition, cautions for their near future of gerontological transition with more and more persons reaching and surviving to higher ages. Services for long-term care, living arrangements, income and social security, protection against abuses and emergency care. The Arab country progresses to population aging, showing a transition of values and norms. Nevertheless, it has an interest. Considerable care provisions along the traditions emphasizing women and labor policies strengthen the informal care. In order to address the baby boom of yesteryears, labor and socio-economic reforms to turn the inflow into employment growth. There is a demographic imbalance in the UAE and other GCC countries born out of a small number of indigenous native population. Still, the structural changes underway in the Arab world are a dominant paradigm for population and development. An unmanaged demographic dividend causes political turmoil, security concerns, and civil conflicts. Nevertheless, there is a direct relationship between dividends and GDP as it influences the dependent load, and thus the public policy is needed to scale up the effect of age structure alteration.
Dr. Ashraf, could you please put your presentation in the presentation mode, PPT in the presentation mode? Yes, please. Go ahead. Please.
The Arab countries' diversity was observed through contrasting economic and social situations. However, there were diverse trends and patterns between countries. Thus, the classification of the Arab world into 4, such as GCC, other West Asia, Arab Maghreb, and Nile Valley African Horn, is justified. Still, population of the Arab region grows continuously with declines in growth rates, stalling fertility, higher fertility, rising life expectancy, changing age composition, decreasing share of childhood population, and increasing old age population with countrywide differentials and diversities. Arab demography to youth births, political transformations, food price hike, inflation, inequity, and wealth gap, whereas the Arabian Gulf countries' market-based economies differ from other Arab countries. The current analysis aimed at appraising the aging process as an end product of the demographic dividend, the reality of the decades to come. Apart from the population aging scenario and the demographic dividend, analysis were carried out to demonstrate age-based indices and the broad age group distribution. The current analysis based on the international database of the US Census Bureau for 3 decades by taking 4 time periods, 1992, 2002, 2012, and 2022. Out of the 22 Arab countries included in the Arab League, data on Palestine were not available. There were no other unified comparable data source for the region except the United Nations population prospects. The demographic indicator of economic significance to employment, productivity, and contribution to the national economy, namely the demographic dividend. Dividend emerges as the current trend in the Arab world. There were 3 different scenarios explained due to the theoretical and current day practices. Traditional definitions of this variable as a ratio of working age to the others, however, with the improvement in life expectancy, health status, and declines in fertility and mortality, hardly anyone enters the labor force before 18 years. Moreover, a student crosses 20 years while graduating or professionally qualifying. So the second scenario sets the working age as 20 to 64 years. Still, competition in the professional field and entry into the employment in the service sectors are delayed further. A third scenario of working age as 25-64 years has been considered. All these calculations were carried out for males, females, and the total for the 4 periods. As expected, due to the large numerator, the results of scenario 1 will be the highest, scenario 2 will be the higher, and scenario 3 will be lower. Countries of the Arab world, especially those of GCC, struggle to integrate their adults into the productive labor force, thereby utilizing the window of opportunity created by the demographic dividends. Middle Eastern countries connecting with the population and development, creating opportunities for economic growth and reaping the opportunity through which macroeconomic strategies and changes and fiscal regulatory labor market policies enhance employment prospects. The Arab world has to respond to benefits from the demographic dividend and the population momentum by adapting its economic, social, and political institutions. In the GCC sector, dividends have been acclaimed to be very high and rapidly increasing over the period. On the contrary, the ratio of other West Asia is lower than the expected, but with an increasing trends. The Arab Maghreb sector shows a higher ratio but a slower increase. In the Nile Valley African world sector, a low and stagnated ratio was found. Improvements were slow compared to other sectors. The age pyramid of the Arab world appeared expansive in shape, showing a higher percentage of children. The percentage of old-aged population was low in 1992, which remained intact till 2012, whereas that of 2022 shows expansions with a shrinking of the childhood population. Along with the expansion of subsequent ages, the age pyramid showed some change though little in 2002, indicating that there was some decline in the percentage of children and those in the subsequent years, but a slight increase in the older ages. It gained an expansive shape in 2012 with a broader base expanding at the subsequent ages. Age pyramids of GCC showed an unexplained trend. It was due to the influx of the foreign labor force. The other West Asia population pyramid was more revealing of the trend of changing age structures towards reducing the percentage of children and increasing percentage of subsequent categories. The age structure of the Arab Maghreb shows a trend of constriction and a further reduction of the percentage of children. The age structure of Nile Valley African Horn sector changed from an expansive shape in 1990 to a less expansive shape in 2012 and a constriction in 2022. Thus, intervention strategies aiming to maximize health and well-being in old age might focus on an integrated and holistic model with policies and programs to intensify home care. We need to choose approaches to improve education and thereby job opportunities for youth, to strengthen human capacity by way of reforms and engagements. Still, provisions for care of older persons, the dire demographic needs of the decade, has many ways to address, such as disease surveillance, preventive geriatrics, promoting healthy aging, research on aging, disease burden analysis, improving healthcare provisions, evidence-based policies, a mix of formal and informal care system, long-term care services complemented by education, respite, medical appointments, and financial assistances to care for aging are valuable. It recommends a partnership between governments, NGOs, and the private sector for capacity building and development of needed tools for policy and programs and action plans with political will. There were 4 indices of statistical significance derived to interpret the age structural composition of the particular population: child-woman ratio, age-to-child ratio, median age, and age dependency ratio. These ratios are useful in demography for structural interpretations of analysis to showcase trends and patterns of population stage-wise along with demographic transition. Changes in the fertility patterns as reflected by these indices press for an acceleration of the aging process in the country that burdens the new generations of adults. Thus, there arises a more rapid pace of population aging, warranting an empowerment of generational support, family care, filial care, and financial support from the formal systems. Overall, the region undergoes an aging process that increases healthcare costs arising from the epidemiological transition, which increases disability demanding long-term care. Pressures of care rest with women in the Arab world due to migration, changing family structure, and labor force participation. The commonly used demographic classification divides the population into 3 categories: children, adults, and old age. A large proportion of the population of the Arab world falls under the adult category. This economically active age has implications for productivity and financial involvement, whose percentage increased from 53.1 to 58.4 to 60.6 and to 60.1. Such an increase would have resulted from a decrease in the childhood population. However, the recent stagnation in this age group could be attributed to the increasing old age population. The Arab world demographics are indicative of gains in longevity, death rate reductions, which accompanied falls in birth rate all over the region, with differentials across geographic sectors and countries, facilitated population aging born out of gains in longevity, epidemiology, and health. All over the Arab world, aging patterns and scenarios transform to the heights through the demographic dividends. The current stage of dividends disappears soon in most of the Arab countries, and thus the sectors and the region as a whole in a decade or two, giving way to the aging of the population. Thus, there are many plans, policies, strategies, actions, and interventions essential country-wise, geographic sector-wise, and region-wise. Thank you.
Thank you, Dr. Ashraf. A quick question. The foreign labor force, was it part of your calculations or not? Because
yes, it is part of the calculation. It is included.
Okay, if it is included,
actually it is a US Census Bureau. They have the total population only. They have not bifurcated into foreigners and the natives.
Okay, then in that case,
to some extent it complicates our demographic analysis.
Exactly, that's exactly my point. Specifically looking at GCC, where the immigration is not present, there is no permanent immigration in GCC, as you know. So, with given the large amounts of foreign population, then your results will be skewed.
Yeah, that is correct. That is correct. Yes.
Okay, but I think in spite of U.S. Census Bureau not giving that information, I strongly believe there are other data sources that can provide you the foreign population versus local population, and then you can get your results much more cleaner to that are specific to Arab demographics. Correct?
There are certain country sources, especially the censuses, which is giving the native and the foreigner breakup. I have used in one of my research. I have used that data in one of my research, but that is not very exhaustive. We cannot really take different periods and all, which is available only for one period or so. But only the Saudi Arabian census gives breakup of natives and foreigners separately, and they have 5 censuses they have conducted. Only one country gives that breakup. No other countries.
There is a GCC-wide breakup as well. I'd seen that data before, the GCC-wide breakup, looking into foreign workforce versus the native population numbers. I'd seen that data before.
Is it the total population by age, sex distribution of population by nationality?
Yes, I'd seen that.
I will look into it. I will look into it.
Please do. Because that problem only exists in GCC, where you have a significant amount of foreign population, and those numbers are available. Okay. Thank you, sir. Thank you so much. And our next presentation is from Roni Sigdar on reproductive burden, caregiving responsibilities in the long-term aging outcomes, evidence from India. Roni, to you, please continue. Dr. Ashraf, sir, please stop sharing, and Roni, yes.
I did. I stopped it. I stopped it.
Thank you. Thank you.
Yes.
Good morning, everyone. I'm Roni Shigdar. First of all, thanks to Longevity organizer for giving me the opportunity to present my work. Now, I'm going to present my work on reproductive burden, caregiving responsibility, and long-term aging outcomes evidence from India. This is the overview of my study. Coming to the introduction. As we know that the gender dimension of the caregiving remains underexplored in the context of healthy aging in India. So if you see the reproductive cycle of men and women, you can see that women are the mostly perform the disproportionate unpaid reproductive and care work throughout their life cycle. So due to the burden of reproductive work, labor market exit and their roles restrict participation in the paid work, and it weakens the long-term economic security and aging security. So the aging outcomes are shaped across the life force are important. So if you see the shifting landscape from more fertility to reducing fertility, you can see that if you hypothetically assumes that the fertility decline always leads to the increased female labor force market, but in Indian context, if you see the developing country are not shaped like that, that female decline has not increased the female labor force participation in India also. So reducing during the demographic transition period, the reducing fertility rate are changing the household dynamics also, and the structural shift. The households are moving from joint to nuclear system, and these shifts create new caregiving pressure that profoundly impacts women in the later well-being. So there are several literatures above on that, and some Esler and Minsar and Hickman, they are studying above on the joint family household persist, where the burden of childbearing and elderly care household course it share, and always there is a negative relationship between the childbearing and female workforce participations. Now, the rationale behind the study is that the current situation and transition from the joint to nuclear family system is reducing the traditional household support, and it placed the intensified the caregiving pressure only on mostly on the women. So, without adequate institutional care like child care in India, we mostly not have seen like institutional care in the workplace also. So this reduces the responsibility, restricts women to participate in the paid work labor force market, and creating the cycle of economic insecurity throughout their life. So um, mm, so this is our objective, that investigates how reproductive and caregiving burden influence aging outcomes, and how it assesses the impact of changing family structure on labor market access, and it examines how cultural norms and social support can alleviate and reinforce this burden. Now, coming to the conceptual, if you see that reproductive life cycle, we can see that women cover mostly the things that unpaid care work. Within the unpaid care work, we see that the child care and adult care, and as well as the older adults and sick care, is also mainly on the women. And if you see the physical aspect of things, that cleaning, cooking, shopping, and the others household maintenance are there. And if you see the mostly biological reproduction, that is wholly depends on childbirth, is depends on women. And see the demographic transition where reducing fertility is happening, where the productive labor market, but work status, paid work, and timely work, all it depends on the women's other things which is covered the reproductive life cycle. Now, coming to the methodology, um, I I used Indian Human Development Survey two weights, 2005, 6, and 11, 12, and our targeted population is the married women. And I use the methods fixed effect regression model and Hickman sample selection model and Corbett regression to analyze our study. Now, coming to the findings of the study, that we can see that from the figure 1, that this figure shows a large number of women move from 1 to 2 or more number of children, but the transition from 3 to or more children are substantial. And if you see the sector-wise transition from 2004 to 2011, so you can see that women are more likely to remain or move into the part-time work and or the informal sector rather than the full-time work. And if you see the work transition also, we can see that exit from the paid work are common, especially among women experience fertility transition. So repeatedly exit from the labor market, which is accumulated into the long-term economic consequences or disadvantage for the women. Now, employment transition for the household types and burdens, we can see that the women from the joint family without no adding children, joint family relatively with adding children relatively better employment continuity rather than the nuclear family. So, in nuclear family, we can see the reproductive burden translate directly into the exit from the labor market. So from this perspective, we can see that the joint family contribute more rather than the nuclear family. So birth transition from 2005 to 11 by household asset and annual hours, we can see from the poor, we create a binary variables, poor and non-poor, where from the poor, we can see that non-poor, we can see that women from the non-poor community, the households are better able to sustain work hours, annual workers, even with adding 2 or more number of children in the later transition period. But for the it is poorer women, it is quite different. For poor women, they have to take care of the child for their own self, and it causes the reduction of the work hours within the higher fertility, and it affects them negatively. So from the Corbett regression model, we can see that joint work and dropped work, that additional number of children after 2000 5 is negatively associated with the joint work, and it is positively associated with the dropped work, which I already mentioned that. If you see that fertility transition, if we add more than two number of children, more than three number of children in 2011, it contributes the more probability of entering the paid work rather than the drop from the labor market, and it's substantially less likely to enter the labor market. And if you see the education wise, we can see that higher fertility increases the less likelihood of existing from the labor market. And if you see from religious wise, we can see that Muslim women are mostly are most probably exit from the labor market. Even if we control the others variables also, their probability from the labor market is more higher than the others religious group. If we see that here also that joint family both are negatively associated, not that much highly adding the extra benefit for the women to entering the labor market. And now the Heckman selection model for working hours and as well as the annual work hours, we can see that the number of age is contributing to the age is contributing to the most likely to labor market, also positively associated. And if you see the women's education, that the annual works are if graduation and above, if women have, they are negatively associated, mainly the below level of education contributing more working hours rather than the highest education. And the joint family contributes the more joint family conditions is more helps to women to participate in labor market. And if we see the social network that contribute more wastage of time, that reducing the participant contributing the labor market. And if you region wise, we can see that Northeast India has negatively associated with the labor markets, and full-time workers is more positively associated with the labor market outcomes. And if it is the annual earnings, we can see that age-wise is negatively associated. Here also the social network is negatively associated, and that is social networks contributing more wastage of time. So it is decreasing the annual earnings. And from household type, we see that salaried women are more positively associated with the annual earnings. So this suggests that the fertility affects not just whether women work, but the quality of their employment also. So lower work intensity reduce the cumulative caregiving over the comparatively less labor market outcome. So
Ronnie,
now,
please wrap it up.
So from the findings, we generally concluded that women with fewer children and access to social network better combined to paid work and caregiving. And for full-time work offers the highest earning, but is hardest to maintain under heavy reproductive burdens. So our suggestion that if we expand the access to institutional long-term care service to reduce the unpaid burden, and if we promote the gender equitable policies and strengthen social safety, that will reduce the reproductive burden. And the conclusion, we can say that reducing the disproportionate caregiving burden is essential for women's the dignity as well as the financial independence. And final takeaway from this study that women's empowering economic progress requires balancing the reproductive and productive labor. And the women's aging outcomes are set long before the old age. So throughout that fertility decision and the lower labor market exit during the reproductive life cycle. Thank you.
Thank you, Ronnie. Our last presentation is Dr. Sulabha Diokar. Her conversation is going to be on symbiotics, a key for healthy aging in menopausal women. Ronnie, could you please stop sharing? Thank you. Dr. Sulabha Diokar. Divya, she's here. Dr. Sulabha is...
Yes, sir.
She's there.
Okay. Okay.
Yes, sir. Good morning.
Good morning. Please go ahead.
Yes, sir. WP. Give me a minute. I will share the screen, please.
Yes, please. Ma'am, are you encountering any problems?
Yeah, yes, sir. Just a minute.
Okay, on the bottom there is a green button. Yes. Ma'am, do you need any help?
Sir, facing technical issue, I can't share the PPT. Just give me 1 minute.
Okay. Divya, do you have the PPT of Dr. Sulabha?
Yeah.
Can
I
you
think
share
we can
the
share.
PPT?
Yeah,
Yes, please.
I will ask.
Ma'am, we can share your PPT.
Okay, thank you, sir.
Go ahead, Divya, share PPT, please.
Yeah. Chaitra is sharing, sir. One. This is the reason, one of the major reasons we made PPT as mandatory.
Yeah, I know.
Thanks for that.
Yeah, we'll share, madam. One second.
Divya, Chaitra.
Let's go.
Chaitra, can you hear us?
Sir, just give me 1 minute. I'm just downloading that. I'm opening that video.
Okay. Sorry for the interruption, guys. So, time to time, we do encounter technical challenges, and unfortunately, it's taking a little bit time today. We had similar challenges as well. Ma'am, from which university are you, ma'am?
Sir, I am from Savitribai Phule Pune University.
Oh, okay.
Yes, sir. I'm working at LongevityAsia College.
I see. And feel free to share a little bit more about you, ma'am, about your research and your background. I would love to hear.
Okay. Sir, I am basically microbiologist working in microbial biotechnology, fermentation technology. This work I'm going to present on importance of the symbiotics on menopausal women. I want to concentrate on the one group that is women in menopause. So, why I have selected this platform, because this platform will give me opportunity about to create awareness about create a diet chart. That diet chart include the prebiotics as well as symbiotics as well as probiotics. Okay. So symbiotic, it is a combination of prebiotics and probiotics. Generally we can say it is a traditional food, okay, fermented food along with fiber rich food. We have to increase in the diet of the menopausal woman. Let me introduce. Okay, see,
Yes,
starting. Okay.
yes, ma'am.
Sorry for the interruption, ma'am. Can you go for full screen option?
Please go ahead, ma'am.
Yes. Thank you, and sorry for the delay. So my name is Dr. Sulbhat Devkar. I am from Pune, working at LongevityAsia College. I selected this platform because of government authorities are here on this platform, policy makers are here, health experts are here, and this platform covering whole Asia. So I want to spread awareness about menopausal women and their diet chart. My research is at the primary level, data collection. Menopause and health challenges. So in the menopause, estrogen declines and it affects the metabolism as well as immunity. Gut microbiota, which becomes a less diverse, and increased inflammation and gut permeability. We can see. Next slide, please. Yes. So, what happens in gut microbiota? There is estrogen regulates the estrogen recycling. Disrupted microbiota alters hormonal balance. This is important thing. And what happens? Important pathways for interventions get affected. So, what are the symbiotics? This is a synergistic combination of probiotics and prebiotics, which restore gut balance and improves resilience. And basically, it enhances the beneficial microbial growth. When we see authentically what are the symbiotics, it is a combination of probiotics and prebiotics. So, according to the WHO from 2001, it is defined as live microorganisms which, when administered in adequate amounts, confer a health benefit on a host. And when we go to the prebiotics, which are non-digestible food ingredients that promotes the growth of beneficial microorganisms in the intestine. Next slide, please. So when we think about the probiotic strains, means microorganisms which play important role as a probiotics, there are three species are included. Some are bacteria and yeast. First one is Lactobacillus acidophilus, Bifidobacterium bifidum, and third one is a Saccharomyces boulardii. And these three species generally used traditionally as well as in the modern way as a probiotic strains, and they work as to boost the gut integrity as well as immunity. Next slide. So, when we go to the next part of this prebiotic components, there are mainly three components we will get. First is the inulin, we will get in the rhizomes of the roots, then FOS as well as GOS. Okay, so these are the fermentable fibers supporting the SCFA production, means short chain fatty acid production, and which will promote the growth of beneficial microorganisms. So health benefits, the combination of symbiotics which lower the inflammation and oxidative stress, which improve the lipid and glucose regulation and enhance the intestinal barrier. Okay, so these are the some health benefits. A most important problem in the menopausal human, which is osteoporosis. So these short chain fatty acids, which improve the calcium absorption and support the bone of mineral density. Next slide. So it works on the gut brain and urogenital axis also. The probiotics which improve the mood and cognition, supports the neurotransmitter balance, as well as which is important in the menopausal woman, which is a vaginal lactobacillus level, which keeps the pH of the vagina acidic in nature. So probiotics are very important into the menopausal woman. Next slide, please. So these are some things which should get included into the menopausal woman as the source of probiotics: cheese, yogurt, buttermilk, kefir, and fermented foods, which are traditional fermented foods. And in the form of symbiotics or prebiotics, we can take garlic, onion, banana, and whole grains. So this combination of probiotic and prebiotic, which will increase the dietary resources and it will help improve the health of women menopausal period. So conclusion: symbiotics, effective non-hormonal support to the menopausal woman, benefits across the metabolic and human as well as mental health. And for this, further clinical validation is definitely required, and government as well as policymakers, healthcare experts, and experts from the all over Asia, they should concentrate that these symbiotics comes to their diet chart. Next slide. And these are my references, and thank you for your attention.
Thank you, ma'am. Thank you so much. And this concludes our day 3 of conversations. And now we'll move on to the valedictory. Is a valedictory meet. And I invite Dr. Varalakshmi Manjana to continue the conversation further.
Sir, 1 minute. Before the valedictory, I would like Abhishek Anand to thank the chairperson.
Okay. Abhishek. to you.
Abhishek? Raghunath, can you thank the chairpersons, please?
Well, it looks like we have another technical challenge here. That's okay.
So
That's
I
okay.
would take the lead on thanking Professor Anil Krishnan and Dr. Shashank Asili for conducting this session very meticulously and giving their time. So I would thank both of them, and now we will move on to the validate.
Varalakshmi ma'am, to you, ma'am. Varalakshmi ma'am?
Yes, I'm available.
Okay,
Yeah.
okay. Please go ahead. We are waiting for you.
Okay, thank you. Good afternoon, everyone. So we have now successfully come to the third and final day of the Longevity Asia Longevity and Healthy Aging and Quality of Life, this second international conference. And from the time the program is initiated and inaugurated on 9:30 on 20th, we can see the overwhelming audience as well as the presentations. So we could hear and witnessed the scientific perspectives from biological, socio-economic, as well as societal and social work perspective, as well as some of the physiological backgrounds and innovative approaches towards the longevity and healthy aging. So we can see the participants eagerly presented their papers from across different states and also from outside the country. And the number of presentations, maybe the next overview will be mentioned by the other colleague of mine. So to take the valedictory address forward, I would like to thank all the organizing committee, my colleagues and steering committee. And here I can say that the valedictory address, today's guest, Professor Mala Kapoor, who is a scientist, a social scientist, as well as the professor from University of Delhi, who will be delivering the valedictory address for the session today. And we can see her major interest in the social policy, quantitative social research, and qualitative social research. And she has very vigorously contributed through her research as well as her contribution as a committee and the vital committees of the country, as well as her prominent social science contributions, as well as her research majorly focused on elderly abuse, as well as the migration and end of life care, and especially the older care persons, which is very highly suitable to the conference of the day. And she is internationally and nationally known as a socialist and social scientist, as well as the social gerontologist. Her work on health and development and social sciences perspective and she has various positions and scholarships to her crown. And she's known for her social scientist perspectives and contributions across the country and also internationally. She has published in various impact journals, served in various ministries of government of India and NGOs for aging issues. And she has also been involved in Ministry of Social Justice and Empowerment in formulating the national policy for older persons, and is also part of the working group of senior citizens. And she is member of various national committees for older people and human rights, as well as she is known for her very active member of various elderly policies in the countries. For example, not only national policy for older persons, but also in the revision of the draft of national program for healthcare of elderly, as well as the senior citizens policy in the country, which are existing and which have been formulated since years back. And to say her several contributions we can count on, but to cut it brief, I'm happy and privileged to introduce her as a valedictory guest of the day for this valedictory session. And I'm happy to invite her for the valedictory session. And coming over to the other presenters, we have seen several presentations, and we have also witnessed the panels which were actively taken over, and we have not even identified that we have come to the end of the conference in the third day. And in that manner, it has very actively and eagerly taken by all the audience as well as the members, volunteers, organization committee. It is a great success. And with the thanks, I give over to the chief guest of the session, Professor Mala Kapoor. Over to you.
Uh, Thank you, ma'am. Can you hear me?
Yes.
Yeah.
We can hear
Okay.
you. Thank you.
Thank you.
And please take
So
over. This
thank
is
you.
over to you. We would like to hear from you.
Yeah, thank you. And I appreciate the introduction. I'm grateful for that. And greetings to all participants at this valedictory session of the Longevity Asia 2025 conference on the theme Aging, Longevity and Quality of Life. I think time is ripe at this closing ceremony for us to congratulate the organizers, panelists, paper presenters, and all the experts chairing the sessions for keeping the focus of the deliberations on very pertinent issues related to understanding longevity concepts, longevity issues, concepts of healthy aging, factors related to socio-economic and cultural diversity that impact on our understanding of longevity, quality of life issues in the context of aging, reviewing techno innovations for longevity, bringing in policy frameworks that impact on different aspects of aging, encompassing various dimensions. By now, all of us connected with this event are fully aware that population aging is a mega trend. And in the present times, it is, as well as in the coming decade, will reshape the economic and social landscape of Asia, also of many other regions of the world. Our region countries are experiencing demographic shifts at unprecedented speed, accompanied by increased longevity, changing epidemiological patterns, indicating burden generated by non-communicable diseases, in some sense, more than by communicable diseases, and reflecting evolving family structures with implications for care systems in nations and concerns about the quality of life of people across the ages. So these are urgent challenges that no nation, regardless of its demographic stage, economy, and development resources, can afford to ignore. All of us living in India, which is marked by being one of the most populated countries for all age groups and experiencing aging at a fast pace, as well as those from other Asian nations in similar demographic transitions, are concerned about aging well. We see in this region conscious efforts by policymakers, experts, researchers to explore how the well being of aging populations, in particular, be strengthened as they are vulnerable section of the society. No doubt, the various countries in Asia have made a considerable progress in the economic and social arena. Yet, the rapid expansion of the segment of older person demands proactive and tailored policies to ensure they age well, as is being also expressed in different reports of many institutions based on various national surveys. Voices are being raised in many quarters of aging countries for investment in quality infrastructure, for building age friendly environments, bringing pension reforms, improving social security mechanisms, achieving universal health coverage, supporting long term care systems, empowering families, communities to facilitate homebound aged care provision, and also create atmosphere for making geriatric care services available and acceptable. Let's not forget the need for equipping various stakeholders with robust data and analysis on aging issues that can lead to informed decision making on enhancing longevity, along with improving quality of life for populations as they age, and being mindful of the fact that a larger segment of the oldest old is increasingly becoming part of aging societies. Here, it would be amiss of me if I don't remind each of us to pay greater attention to how do we improve our methodology for measuring well-being and quality of life parameters that have health, social, economic, cultural, and psychological dimensions. Amidst all these thoughts, it is important for us to understand that while experiencing greater longevity is an achievement in Asia, but it brings in many challenges connected with persisting relative poverty rates for older people, which influence them being disadvantaged in resource allocation within households, and it drastically affects their quality of life. In addition, physical and mental health challenges become more acute with age, and it makes them vulnerable towards increased loneliness and social isolation, which, along with insufficient access to health and long term care, impacts their well being in the most undesired way. Further, as many studies indicate, and also pointed out by the latest ADB report on aging, pervasive informal employment and gender inequalities seen in Asia that additionally impedes well-being in old age. Significantly, older women in India and in other countries in the region too have advantage of longer life expectancy, but their morbidity burden is higher than that of older men, and this makes them feel greater insecurity in old age. This definitely impacts their quality of life negatively, as pointed out in many research studies. We, as experts working in the aging field, know about the criticality of four key dimensions of older persons' well being that relate to their health, productive work, economic security, and social engagement, with the first being of paramount importance, as the rest three to a large extent depend on it. Therefore, a challenge in Asian countries is to adopt policies and programs that encourage and promote a life cycle and lifelong approach towards well being, which can influence having better quality of life in later years. The COVID pandemic was a lesson for all of us, as it made us conscious of the fact that older persons, among whom the burden of non communicable diseases is higher, are more prone towards communicable diseases and are also more affected by climate change, as much of recent research is indicating of the drastic impacts it has on their quality of life issues due to many of these factors. There is ample evidence emerging that in India and even in, for instance, Bangladesh or Indonesia, lack of adequate provisions of essential services for older persons is a hindrance towards optimizing their physical and functional capacities, which negatively impact their well being and hinder them experiencing better quality of life in old age. A critical Asian challenge is prevailing ageism that does not promote health investments over a lifetime for ensuring good old age, despite the prevailing traditional medical systems, holistic health concepts. Old age has seldom been thought as a productive, active phase of life where social engagements remain meaningful and purposeful. However, I'm glad to note certain positive and progressive mindset changes happening in this direction since the beginning of this century, not only in India, but also in other Asian countries. Still, nonetheless, these developments need a societal push. Thus, I feel there is an urgent need to emphasize for a life cycle perspective on healthy aging that emphasizes continuously and persistently on consumption of healthy diets, maintaining healthy behavior and lifestyles, living in healthy environments, and investing in primary healthcare infrastructure by bringing in an integrated system of healthcare delivery to serve the physical and mental health needs of people of all ages. This corresponds well with the concept of successful aging, which is associated with being able to live an independent and autonomous life, not necessarily free of any disease. This paradigm correlates with public health approach that allows us to look at health promoting interventions which may prevent functional loss both in physical and mental terms, thereby promoting quality of life and facing the challenges of longevity revolution brought in by fast expanding aged populations. In this context, to this August gathering, part of the conference today, in the valedictory session, I would like to draw your attention to the fact that there is pertinent need to pay greater emphasis on the potential of self care behaviors among older adults to prolong independence in later life. We also need to consider the utility of assistive devices and technology for enhancing self-care capacities in dealing with activities of daily living. Studies have shown that those individuals who follow unfavorable patterns of self-care throughout their life experience greater risk of mortality compared to those with a favorable pattern. And this, to my mind, is a crucial beneficial intervention in encouraging self-care behaviors that can then constitute towards better quality of life in old age, irrespective of fast longevity increases when threat towards increased incidence and prevalence of comorbidities is visualized. Another advantage is that when functional capacity stays stable with limitations removed or taken care of, then mental health too improves, which in turn reduces for older persons their sense of isolation and improves autonomy and self esteem. In short, enhances quality of life. I would like to stress in this validatory address that in this context, another pivotal aspect for Asian countries to consider while facing challenges of longevity revolution relates to governments fostering greater financial literacy, inclusion, and preparedness for retirement among aging populations, along with enhancing economic security in old age through pensions, health insurance provisions, etc. It is absolutely essential, in my opinion, for governments to empower citizens to prepare for old age and also encourage longer working careers by giving opportunities for midlife skill development, not only in terms of making them capable of earning better, but as well as remaining useful in families, communities, going along with changes in societies affected by globalizing technological developments. In no way should a societal movement in aging societies with increasing longevity ignore a lifelong life cycle, population wide approach to meet the aging challenges. A pertinent concern related to intersectionality between longevity, aging, and quality of life emerges from initiatives being taken in societies in supporting aging in place and providing support to families in caring for their older members. There is urgent requirement for filling in gaps from gender considerations in care provisions being made hollow by increased care needs of older persons, especially during their last few years of life, and changing family structures and relationships affected by contacts taking a digital mode. It is crucial for our societies to embark seriously on furthering our understanding on long-term care provisions and uses of technology. We need to seriously focus on inclusive and right-based approaches and perspectives for aging well and fostering care economy for our present and future heterogeneous generations by using comprehensive measures of quality of life for aging populations and by keeping abusive situations at bay and encouraging age-friendly environments and social participation, which to me is important as a lot of my work in last few years relates to these aspects and aging Asia. I would like to end now, and with these, I request you to take away some of these thoughts and come out with more research which connects the three aspects of this important conference and critical issues. So thank you for your patient hearing.
Thank you, ma'am. So it is, I could say that it is a wonderful closure of the session. And having heard from you, I can say that. So when you are saying the valedictory address, you have not left any stone unturned. You have touched upon the highlights of healthy aging. By having mentioned, you have started with a note of demographic trends in the country as well as the globe. Need for the inclusive, that is a socially inclusive aging process to happen. And as you have rightly mentioned, yes, when we are living longer, it is responsibility of everyone to make sure that the aging people lives with dignity, with inclusiveness, where the gender responsiveness is essential, as well as aging sensitive, as well as inclusive society, as well as policies. Yes, you have touched upon that. And having said, when you have said functional capacity, yes, that is one of the promo of healthy aging also. Healthy aging essentially mentions functional ability and well-being in older age. And you have rightly mentioned that how the functional capacity is essential, and also stating that self-care practices are essential for the older aging. So that is not just the responsibility of any one sector, neither the government nor the individual. It should be a combined effort of the individuals as well as families and society, as well as the government policies should join hands along with the NGOs and other voluntary sectors has to combinedly work for this healthy aging to happen. Then only aging people will be living with dignity, without any regrets, without any lack of purpose. When you have said that aging people are inclining towards the loneliness and social isolation, so maybe the social transitions and family dynamics are very drastically changing in the India too. Though having known India is known to be a country where the world looks at the family system of India, but however, in the recent decades, we also very swiftly changing our family dynamics. And however, we have to hold up the emotional ties and also look into the alternatives of keeping our bonds together, so that nobody in the family, none of the ages in the family are feeling left out. So we are not supposed to leave our older persons in the family system also filtering out of the net of the family care. When we said family care, we need to preserve our informal care systems as well as the formal care through the social care resources and healthcare resources. You have touched upon very well all these points, essentially highlighting the need for building evidence and research on geriatric services. What are the components we have to look into to make the life course approaches for the aging care as well as the aging research? And also, I would feel that even all the funding agencies and supportive systems, starting from the government as well as voluntary and NGOs, those who are working towards the aged care also should highlight the need for bringing more evidence, more research towards the aging care, so that geriatric care should be part and parcel of our research process. And also, the need-based care for the elderly has been shifted to right-based, where enabling environment is essential for healthy aging. And all the people who are aging should not start from the only 60 plus or 65 plus. And we should start thinking about healthy aging in the life course perspective. So thank you for bringing out all the essential components. Also, you have touched upon gender-based. Older women, though they're living longer, are they living healthy and also economically preserved? So thank you very much for bringing out social perspectives, policy perspectives, and also the need for making aging in a healthy manner, productive aging, and also active aging pillars of health, participation, and social security. All these points very well touched upon. Well taken, ma'am. And we have all been working and hope our future generation and our research scholars who have presented various perspectives of these aged care directly or indirectly. We are going to take this message forward so that we will build up more aging research towards making our societies inclusive, gender responsive, age sensitive, and healthy aging and healthy nation. Thank you.
Thank you very much. Thanks for your appreciation and gratitude, and happy to be with all of you to take this forward. Thank you.
Thank you, Mala ma'am and Varalakshmi ma'am. Now we will move on to the conference report by Professor Anil.
Yeah, thank you, Mala ma'am and Dr. Varalakshmi. And now I ask Raghunath is going to show a small PPT, and I'm going to start with that. Raghunath?
Sir, I hope the slides are visible.
Yes, I can see. Okay. See, as we mark the end of the second conference on aging, longevity, and quality of life. It is my privilege to talk about or take you all through the outcome of the conference. Can you go to the next one, please? Raghunath, next slide, please. Raghunath, can you hear me? Yes, go to the next one. Yes. See, as we all know that we have about 6 themes and some sub-themes, which was designed when we had a thought in our mind. The major objective of keeping those things and looking at the current scenario of aging in Asia and how we could potentially merge these things and giving an opportunity to the researchers to come forward and provide as a thought on their research outputs. Go to the next one, please. The day of the conference came up with the inaugural session by Andrea. Is a country representative of UNFPA India. She essentially emphasized on longevity as a societal opportunity and working through the society could potentially increase the longevity. That's what one of the key points which she was mentioning in the inaugural event. And it also should have a gender responsive aging policies. When we look at it globally, most of the program now we are focusing on gender inclusive policies. That's what the major focus of that. Then the care, strengthen the care economy. See, the basis of the entire concept of the population lies with the economy. How this potentially be diverted into the improvement and increasing the longevity of the older person, which was another emphasis by Andrea in her inaugural session. See, the last point which has got a importance in the Asian context, with most of the countries in Asian context are low and middle income country group, where the social protection systems are not really in place. When we talk about the social protection, which is critical for the mass aging population. Can you move to the next one? See, when a comprehensive view of the total number of paper presented, it was 52 with the breakup, which is already in these slides, with the maximum number of paper from the socio-economic and cultural diversity, which there is no need to surprise, because people are now working on the cultural diversity and socio-economic part rather than talking about the other components. Next slide, please. On the day one, we had about 12 participants. The first session, the 12 participants presented their paper on various aspects, out of which the major factors which brought into the group was on life course, on health risk. Then, linking health, women's health, and various occupational factors. That was the highlight on a couple of sessions. Then the more attractive session to the health care group was a multi-morbidity cluster within the individuals. That has got various components like behavioral factors, environmental factors, and integrated preventive care. Those things are clubbed in multi-morbidity clusters with individuals. Then psychosocial and cultural factors, as I mentioned earlier, playing a critical role in the Asian context, that was also highlighted in that section. And when we look at the presentation outcome, the findings are essentially focused on the context specific and gender responsive, and some of the things should be aligned with the decade of aging, healthy aging by the WHO context. Can we move to the next, please? The second track, which we got about 8 presenters. They presented their research outcome with a major focus on mental health, chronic diseases, climate change, workforce issues, etc., in addition to the health financing. There we also received some of the papers related with improving the quality of life, etc. See, the different papers came forward with the comparative analysis where it was made the audience interesting. One of the things which we would like to take the note of, there are two things which was very different. One is a techno stress and procrastination, which was a different angle, which gives us some thoughts into that. Then we also saw a machine learning application and how which could be potentially screened for hypertension, and that particular model is also one of the interesting paper in that. In addition, there were papers which focused on the climate impact and environmental factors, which was also part of this group. The major emphasis was in the entire section, which was a dimension which is caregivers, particularly in the context of Alzheimer's disease and the dementia. That paper was also discussed in detail in this particular session. Can you go to the next one, please? That ends the first day of the presentation, and the next day morning, that is the 21st, the second day, which started with a panel discussion with the eminent panel members, Professor Shekhar, Malti, Anil, and Niral, which was a thought-provoking session, and give a very good attention and appreciation from the participants, where they noted the key challenges, especially on the Indian context, was being clearly articulated by T.V. Shekhar, followed by Malti and other things. In addition, a global perspective was given by Dr. Niral with his experience in the Western world, including US and other countries, which give us different thoughts on how it could be. One of the potential thought given by Dr. Niral was on pharmacy to your doorsteps. That was another idea which gave by the one of the panelists. Then when we talk about some of the opportunities where the silver dividend, which was across the board. This was being discussed, and how do we tap the resources to improve the health of the aging. And this also could be an experience with which India could potentially be used. And in the concluding reflection, dignity in aging cannot be delivered by the government alone. That was a message which came, and it also requires intergenerational bonding with the PPP, public-private partnership, and that is going to be a paradigm shift in improving the lives of the older persons across Asia. Can you move to the next one? After the panel discussion, we had another session track, which was 11 people, participants were presented across different areas, in which they have touched upon several determinants of government health expenditure, research on primary focused on elderly care and chronic diseases, and also determinant of vulnerability, etc., have been discussed in that session. And the collective deliberation underscored that ensuring the dignity in aging requires a right-based life course and equity-oriented approach. That was the conclusion from that presentation. Can we move to the next one, please? And the next presentation, we had about 10 presenters, which was on the socio-economic and cultural diversity, where they brought about several aspects, which includes study in the home, old age homes, family settings, then better cognitive health, etc. Where worked. The highlight of that session, which was often the researchers overlooking the socio-economic and caregiving contributions of the older adults, which needs to be incorporated, and intergenerational solidarity to be strengthened. Can you go to the next one, please? In the last session, which was today, this morning, was the third day of the presentation, Longevity, Aging and Health Policy Impacts, where 9 presenters made their presentation on non-communicable diseases and some of the policies of older person in India, and one study compared India and Delhi. And so one study in Goa emphasized on the old age homes. They mentioned about it. Then one interesting study on spirituality. Then one study was on the African context. In the Middle East context, Saudi Arabia and other countries context, which is a demographic dividend in Arab countries, when we look at those policy papers, which have very highly relevant in the context of Asia and improving the policy concept. With that, I think we have already completed the entire conference reporting. Then I have a few more points to discuss. I'll quickly wrap up in another 2 minutes. Do you have any another slides? Raghunath, any other slide? If
yes,
not,
sir, there are
I
a
can
few.
talk about
Yes,
that.
sir.
Okay, so can we move to the next one?
Just a moment.
Yeah, sure. Okay, so then we have the validity address by Professor Mala Kapoor Shankarda. She emphasized a lot, and Dr. Varalakshmi eventually, reiterated those things, and that thought-provoking validity address gave us the different ways of thinking and how to improve the longevity and healthy aging in Asia. Thanks for an excellent validity address, ma'am. Can you go to the next one, please? No, I just wanted to touch upon the emerging priorities of longevity aging. There are several emerging priorities. First, a life course approach to healthy aging. Longevity begins long before the old age, as we all know. That needs to be considered very seriously. Second is rethinking the health system to the complexity. Older adults increasingly live with multiple chronic conditions, mental health needs and functional limitations. The health system must move beyond a single disease model towards the integrated model. I mean, that's what we all think for. The third point is a long-term care as a development priority. Families alone cannot no longer shoulder the burden of the care, as we all know that Asia need a sustainable long-term care system with the development priorities. And the fourth point is the addressing inequality in aging, which essentially talking about unequal. The policies are unequal by gender, income, geography, marital status, and the policies must be inclusive, addressing the inequality in aging. And finally, harnessing the potential of the older person, which was discussed well throughout the conference. The older people are not only the care recipient, they are also caregivers. Essentially the workers, volunteers, and community leaders, they are enabling their participation for a lifelong learning system. That is going to be the another one. Can you move to the next one? Raghunath, can you go to the next one? Okay. No, sorry. The way forward. I'm talking about that. See, I'll also briefly touch upon what is the way forward. As I was observing the whole thing. The first we need more Asia-specific context-sensitive research. Although we have several research, but we need to give more focus on Asia's diversity to be focused, and behavioral research, etc., to be part of that. Second point, I would strongly focus on research must move beyond disease to function and well-being. Future studies should prioritize, healthy life expectancy, functional ability, mental health, social participation, quality of life. These are all there, but it needs to further strengthen. Third, we must strengthen the longitudinal and life course data. In India, we have LRC data, similar thing which other countries having, then we should start analyzing it as a researchers. And fourth and important thing which I as a person propagate here is the implementation research that must be scaled up. And I didn't find any of the implementation research paper throughout our 52 presentations. And the fifth, research must inform policy and practice more directly by saying that stronger platforms are needed to translate the evidences into policy making through policy engagement, regional learning. It could be networks or co-production with the government and communities. Finally, the older person must be part of the research. It is not they're not just the subjects. Ensuring that the evidence reflect lived experience in a real need. Yeah. If you have any further slide, can you go to the next one? Yes. And I'm very glad to be part of this steering committee with eminent people. And we have started this a long back. And finally, we concluded the conference with, I would say, with 100% success. To make made this success, we have a group of volunteers. Can you go to the next slide, please? We have a group of volunteers who were the backbones of the entire conference. I sincerely thank each one of you in person. Personally, I thank everyone for the success of this conference. With that, I think I'm wrapping up. And once again, thank you very much for everyone. Thank you, and over to you.
Now I request Professor Dilip to deliver the vote of thanks, please.
Yeah. Good afternoon, and
So I take this opportunity to express the formal vote of thanks to all the participants, sponsors, and invited speakers, and finally to the organizing committee as well as the volunteers. At the onset, I would like to thank Dr. Andrea Wojnar, the UNFPA country representative, for giving an inspiring start to the conference through her opening address. Okay, so it was, even though it was through a video message, we were really inspired. Thank you for the same. Similarly, we cannot forget the support that we received from Professor Mala Shankar Kapoor Das, who is not only a mentor but always a pillar of support. Whenever we have some issue, she is there always. Thank you, madam, for your kindness and all the wish for making this conference a grand success. Then we also invited 4 distinguished invited panelists for the plenary session. We would like to thank Professor Shekhar, who is also my colleague. Similarly, Maldi Jaswal from Inspire Elderly Foundation, Dr. Anil Billy Male, who is a professor at the School of Public Health, JSS Institute, Mysore, and Neeral Shah, who is a general surgeon with interest in geriatric care from Augusta in Georgia. Okay. Then we received a lot of submissions. I would like to thank all the paper presenters from various disciplines for making this as a grand success. We also have to acknowledge the experts who peer reviewed the abstracts that we reviewed and for selecting these exciting papers. Then 2 of the steering committee members have to be applauded. Specifically, Dr. Shashanka Ashley and Professor Dhananjay Bansal. They have been behind this for almost 8 months. In fact, they are the people who floated the idea of Longevity Asia and inspired many of us to be part of it and to take this forward. What we see today is an outcome of their meticulous efforts for planning the event. Lastly, but not, I also would like to thank Anil Krishna, who is a leader in the case of knowledge management in the case of elderly. We are lucky to have him as this. He readily accepted our invitation and was with us throughout the entire journey. Thank you, Anil, for the same. We had Professor Varalakshmi Manchana from University of Hyderabad and her small team of volunteers who were always supporting us in organizing various like session planning, reviews, even chairing sessions, things like that. So thank you, madam, for it. And we cannot forget 2 institutions. Okay, so that is one is Cure Science and International Institute of Population Science, which we come from. So we have these 2 institutions are allowed us to use their platform not only for hosting but also promoting this event. We would like to thank the management of these 2 institutions for the same. One person which we cannot forget is Divya Ramakrishnan, okay, who managed the secretariat for the conference. I am sure many of you might have got wake-up calls, reminder emails, and all those things. So we are able to manage time and so efficiently, mainly because of her. So thank you, Divya, for that. And I would like to end by acknowledging the contribution of our enthusiastic volunteers, Chaitra, Amita, Uma, Numair, Akriti, Abhishek, Lily, Raghunath, Roni, and Shubham for all their efforts related to session management, live streaming of the sessions in various social media platforms, introducing the speakers, and any other small task that which came up in between, not only during the conference or even before that. So thank you all. So I will let us meet next time. Thank you.
Thank you very much, sir, for that elaborate vote of thanks. Now I would call upon Professor Dhananjay Bansud for the formal closure of the ceremony.
Yeah, thank you, Divya. Because now we have come to the end of the sessions, and now this is the time to say bye-bye. Because the Longevity Asia 2025 virtual conference concludes after the 3 days of focused discussion on key issues related to aging and longevity in Asia. The conference served as an important platform for exchanging knowledge, research findings, and policy perspectives. In way forward, Dr. Anil Krishnan has already highlighted the issues that we have to do it. So I will also reiterate the same. The deliberations underscore the need for continued collaborations, strengthen research and evidence-based policies to promote healthy and inclusive aging. Sustain engagement among stakeholders will be essential to translate these discussions into the meaningful outcomes. Because so unless and until we'll discuss continuously, so we cannot do anything. So it's always better to have the continuous discussion on the similar issues so that we can translate this discussion into the meaningful outcomes. So with this, the conference is formally concluded with a shared commitment to advancing longevity research and the practice. So I have some more announcements, like we are planning to bring out the conference proceedings, and you are requested to contribute, or whatever the paper that you have presented, just finalize it and submit it to the conference proceedings, and so that we can bring out proper final volume. And in this regard, the official email will send to you soon. And about the next year conference, we are also planning to have the next Longevity Asia conference that will be in the offline mode, and the date and time plus venue will be communicated soon in our Longevity Asia website. So with this, I thanks all the volunteers, all the paper presenters for their contributions to the success of this conference. Thank you so much. And lastly, I would like to invite Dr. Shashanka to say a few words. Shashank, sir, over to you.
Sir,
I don't
think
think he's in this panel.
He's just left, yeah.
Yeah, he just left because
Okay.
it's too late for him. It's around 2 o'clock, midnight.
Yeah, I thought he's there, so I thought, okay.
No, it's okay. Yeah.
Yes, fine then. So, Divya,
Okay.
you have anything to say last, or any?
Nothing. So I would like to thank everyone for making this conference a huge success, and also congratulations to all the volunteers who have been my backbone for all the success here.
Okay, great.
And thanks.
So lastly, I'll
speaking
just
committee
want
members.
everybody to put on their video so that we can have one group photograph.
Yeah.
I think you have to bring all the people, those who are in the attendees to this platform.
Yeah, I have moved all the volunteers
good,
as
good,
well
good,
to
good.
as the panelists. If anybody is left out, please move. I'll just check. Numer is there, yeah.
Abhishek, please put on your video.
Roni is
Amita,
there.
Chaitra.
Roni, Numer, and Uma. Yeah, I'm moving them. Yamini. Yamini also join.
Yeah, Yamini also you can put.
Yeah.
Okay, so everybody please put on your videos.
Everybody say thumbs up, thumbs up.
Okay.
Thumbs up. Video.
Okay.
So thank you once again.
Thank you.
And
We
we'll
meet
see you
next
soon.
again.
Bye-bye.
Bye-bye. Take care.
Bye, everybody. Take care. We'll meet
Bye.
soon, all of us. Yeah.
Bye-bye. Thank you.
Thank you, everyone.
Thank you, ma'am, so
Thank you,
much.
ma'am. Thank you, ma'am.
Bye-bye.
Bye. Thanks, everybody. Bye.